Good morning, everyone. Good morning. We're running just a little bit late, and I'm glad our council members are talking across the front of the room here. Bless your hearts. So we're gonna get rolling this morning. Our first presenter is Miss Juliet Simpson. She is the Chief Strategy Officer and the co-founder of All Health Choice. She holds a Master's of Social Work from University of Georgia and Bachelor of Science in Psychology and Sociology from Presbyterian College. I think we've got at least one Presbyterian alum sitting at this table, maybe. And so anyway, we're looking forward to what she's got to say this morning. And Juliet, the podium, microphone, whatever is yours.
So much. We also have Dwayne Chapman, who's going to be with us today. Dwayne works with us. He's our Senior Vice President of Sales and Business Development. And so he's going to kick us off, and we're kind of going to throw it back and forth to each other. So we appreciate you having us.
From a PowerPoint, are you going to click that?
Good.
As Juliet mentioned, I'm Dwayne Chapman. I've been with All Health Choice going on a couple of years now, and we do appreciate you guys allowing us to come in and talk to you a little bit more about what we do. Today, our focus and desire is to educate you all on what we think that All Health Choice and our solution, My Charlie, the impact it could have in rural healthcare areas, and we do think this committee is the right audience for us to talk about the things that we do. So, at All Health Choice, our focus is on population health management, and we do this in a couple of ways. So if you look at the population health management sphere, we're trying to work on things such as care management, telemedicine, patient engagement, and ultimately our desire is to improve outcomes, right? And so outcomes, whom are we talking about improving outcomes for? We're focusing on the chronic population. I know you guys have been here for a couple of days and talked about healthcare, the things that you're facing in your individual areas as well as in the state market. And chronic conditions are really impacting us all the way across the board in healthcare. So our solution looks to come in and reduce catastrophic and critical events by transmitting information into our proprietary My Charlie system at a real-time basis with these members, allowing us to intervene at the right time. So as we continue to talk about that solution today, I just want you to keep those things in mind, that the intervention with patients at the right time and reducing red flag alerts and critical catastrophic events potentially from happening. So as you all have heard, and we know chronic conditions are extremely costly. I think that we have seen some things statistically out there that roughly about 80% of our costs typically are driven by 15 to 20% of our population, and that's our chronic population. While that is alarming, one of the more disturbing facts to us and what we feel is a driver for what lets us know we're in the right market is about 2 to 3% of those individuals are actually receiving proper care coordination with the conditions that they have. So if we're not presenting and enabling those individuals to actually receive the right care management that they need, what's going to continue to happen to their claims dollars? They're going to continue to be a huge impact and burden on the healthcare system overall because we're not doing the things necessary to start enabling them to better manage their conditions and reduce and control their healthcare costs. So you can see that if we don't start making changes now, we'll continue to have these conversations 5, 10, 15 years from now, and chronic conditions are still what's driving the underbelly of the healthcare system from a cost perspective. Another key driver that we feel is very alarming to us is 7 out of 10 Americans taking improper prescription drugs. And so when Juliet gets to talking a little bit more about our chronic care management solution, you'll see where we come in and do a pharmacy review with our members, and this is one of the reasons why. There's a lot of claims costs right now that's being incurred through prescriptions that's simply a disparate healthcare system where prescriptions are being prescribed to members by multiple physicians, and there's no communication among everyone involved in that healthcare system of the patient, so they may be doubling up on drugs and things of that nature. So at All Health Choice, we designed our solutions around how we can go out in the marketplace and impact these chronic conditions. And so we've got a chronic condition monitoring program. We do lifestyle management programs and disease management. And so when you think about the population health sphere, we'll see that all of those programs are focused around the management of chronic conditions. It just depends on where you're at as a utilizer, onto where you're at within those programs for us. Care coordination, remote health care, obviously data analytics is a big driver of what we do, and then through that we've also got the telemedicine communication capabilities that you have in our solution. So we do feel that MyCharlie does enable us to have a better way to improve health care. Engagement is the key driver with healthcare. I think we'll all agree on that, and so we'll see how the MyCharlie system allows us to have continuous engagement with the members, leading to an overall reduction of healthcare costs, which generates and helps us tangibly show members, employers, payers, and other health plans the strong financial incentives that come with utilizing MyCharlie. So the first step that we do, and so when we go out into the marketplace, we're partnering with either large self-insured employers. We partner with Medicare, Medicaid providers as well to assist them with chronic care management and the coordination of the things that we're going to talk about, and we partner with other regional third-party administrators as well. So Secure Health's TPA here in the state that we've partnered with for a few years and got some great results that we'll talk about. But the first step that we do is go in and stratify the population. And so while we do have our own analytic tools to do this stratification, some plans come to us and say, hey, I've got the risk stratification piece handled, but ultimately for us, we're wanting to look at the segment of individuals to say, okay, let's identify your population, put them into their risk categories, and then start looking at the conditions and the diseases that are driving their cost. And so when you look at this healthy well in the green sphere of the population, these are your individuals that may have chronic conditions or being diagnosed, but ultimately they're really not a high utilizer of health care. Real claims costs are really low. But what we want to do is ensure that through our MyCharlie application, we're keeping that individual in that sphere of care, because if someone goes from green to yellow, well, their claims costs have now gone up, okay? So you've got to have a solution that engages consumers regardless of where they're at in the sphere of care and stratification so that you can maintain them in their current state. So the unhealthy well in that yellow stratification, those are your individuals that may have diabetes, they may have hypertension. They're a mid-level utilizer of health care. They're driving about 15% of the claims cost on an annual basis. And then the red bullseyes are chronic population. Again, that's kind of what you guys seen and heard yesterday, but we've seen that's about 20% of the population driving 80% of the cost. And so those individuals will be providing with a higher touch solution and engaging them on a more proactive basis on a daily level. And we'll learn more about what that looks like here in a few minutes. So what I want to show you guys now is some of the results that we've seen within our own populations. And so this has been a year-over-year study that we've done with some of our groups. You can see we've got over a 50% reduction in readmission rates. I know you guys, that's something very important to you. The reduction in ER visits down by 70%, 75%, over 90% patient satisfaction. And why is that important? A lot of times when you hear and say, well, you're going to provide my participants, my members with this technology in their home that allows you to communicate and kind of monitor them, but they're not going to like that. They don't want the big brother effect, but we have found that these individuals over time really rely on having someone that they can touch 24/7, 365 and answer their questions, tell them why they're not feeling well, or just kind of bounce that off of them instead of running to the ER. So the patient satisfaction is very important, and then the medication adherence, over 94% as well. And that's something that pharmaceutical companies struggle to get. We all look at what we're feeling from a PBM perspective, and we know that the drugs aren't being managed properly. But when they've got a proactive care manager that's there with them building out their daily schedule and routine on when they should take their prescriptions and things of that nature, it really starts increasing the level of accountability that we see within our members. So what does this mean in actual real dollars effect? So it's great to see that people like it, but is there really a tangible ROI that you can associate with this program? And we can tell you with all certainty that there is a very high tangible ROI that we've seen within our patient population and members. And so we've seen over a 55% reduction over the participants in our program year over year in that population. And so when you look at that population specifically here, I believe that it resulted in over $55,000 to $60,000 a year that these individuals saved in their claims cost. It's significant. Now, these were the high utilizers, okay? So these were going to be individuals in that red bullseye that we were talking about. These were the sick of the sick type deal. So obviously, if somebody's only spending $15,000, $20,000 in claims, we're not going to say 50, but we do feel certain that we're still going to see a 50% reduction typically in their claim dollars. And so then you can see a breakdown, hypertension and diabetes. I think you all would agree that within your populations that you're representing, diabetes and hypertension is a real big driver of claim cost. And so when we looked at coming and speaking to you guys today, it really hit home with us that not only is that a big segment of your population, but being in the rural areas, the access to care and getting the right outcomes is a big struggle that you've got within that group. So we feel like by enabling those members to be able to have access either in their home or on their mobile device and somebody real time, they're not having to drive 30 to 45 minutes to get to a primary care physician when they have an immediate need. So we feel like we're enabling them to start seeing better outcomes and improving the quality of their life. So you can see here that we feel strongly about what we see at a tangible perspective, and as we get toward the end, we'll talk about some of the unique things we even do about going at risk in our contracting as well. So with that, I'm going to turn it over to Juliet to go a little more in depth on what the chronic care monitoring solution looks like. And if you guys have any questions as we go through this, please don't hesitate to kind of let us know. So.
Okay, can you hear that good? Microphone? Okay. Well, thanks, Dwayne. As Dwayne mentioned, we do multiple levels of care, and I'm going to talk to you today about chronic condition monitoring. And the chronic conditioning monitoring is for those highest utilizers. These are people with multiple chronic conditions or at least one chronic condition that's uncontrolled. And we see these are usually your red risk stratification, your highest number. These are folks who may have newly diagnosed diabetes. These are people who may have 4+ chronic medical conditions, at least 3, and people just who aren't adhering to their physician's care pathway or what the physician is telling them to do. So All Health Choice is based out of Georgia. We have an office in Macon. We have a satellite office in Tifton, and we're getting ready to move an office to Atlanta. So we have a 24/7 call center in our Macon location, and it's staffed with nurses. So we provide not only just access to nurses 24/7, but we actually have nurses who are being proactive and reactive. So as we all know, I mean, if you go to the doctor today, you have to go when their open hours are. I don't know about you, but anytime I've ever had to go to the emergency room, it wasn't at 2 o'clock in the afternoon. It was a weekend. It was an after 5 o'clock event. It was something that happened outside the norm. And so it's real important to understand that we're available 24/7. And we're doing proactive and reactive care management. So when we get a participant on our service, and as Dwayne mentioned, we do various types of risk stratification. We have our own risk stratification tools, but we can use the risk stratification tools of the organization we're working with. But through that risk stratification, we look at their diagnoses, what their uncontrolled conditions are, and what do we need to look at on a daily basis to make sure that we're taking care of this person. And so we send them a small tablet, 8-inch tablet. That tablet comes with internet connectivity, so we don't have to rely on the participant having internet connectivity in their home. We saw that and found that to be a huge barrier in the rural areas, especially people who didn't have access to the internet. However, we also have a nationwide contract with Verizon, and so they work with local vendors so that we can access the best service in rural areas. So we determine what medical conditions we need to monitor, and then we send them Bluetooth-enabled medical devices. So if you take your blood sugar, if you take your blood pressure, the device is like any normal device that you would use. It's just Bluetooth enabled. And what that does, it allows the data to transfer directly into MyCharlie, into the software, and the nurse can see, or they receive an alert if blood pressure wasn't taken on time or if the reading was high or low. And that tells them immediately through their dashboarding that this particular participant has a problem, and they begin to reach out to them. So depending on condition, we have pulse oximeters, glucometers, scales, blood pressure cuffs, a thermometer, and then of course the tablet. Again, the 24/7, 365 proactive and reactive nurse-driven care management. And the goal is to build a relationship. As Dwayne mentioned, patient engagement is really key. So we work very hard from the beginning of the relationship to ensure that our participants understand how to use the technology. They have a video conference walkthrough with our technicians so that they can feel comfortable. They have engagement immediately with their nurse who's going to be managing them, and they have engagement with a pharmacist. So we have pharmacists on staff that do medication reviews as well. So they look for issues of polypharmacy, contraindications. They look at, it's amazing what you would find because what we found is that even some participants use different pharmacies for different medications. And so the pharmacist may not know that from one pharmacy they're getting a brand drug, and from the other pharmacy they're getting a generic of the same drug. And of course, we look at cost issues, we look at what's best for their care, but the pharmacists really do a good job of identifying issues to help the participants become more adherent to taking their medicines. And we also manage that every day as well. We have to see them acknowledge that they've taken their meds. And then we have programs, for example, we have an opioid management specific program where we actually work with a pharmacy that provides Medipacks in the home, and so we can scan the Medipacks to make sure that dosing and frequency is accurate. The dosing packs tell us when somebody has skipped a pack or a family member has come in and taken a pack. So we have multiple ways of doing medication monitoring. Our system is completely HIPAA compliant and high trust certified. And that we have HIPAA compliant video conferencing, and that's the way that we communicate with our participants. So the nurse is able to hit a button, and that rings the participant. And if the participant wants to speak to the nurse, the same thing. They just hit a button, and the nurse appears on the screen. So of course, one of the biggest things we do is coordination of care with the primary care physicians, with the specialty physicians, with caregivers, other providers that might be involved in the care. So our goal is to really consolidate and gather all the information, work on patient engagement, ensure that participants are being compliant and adherent to their care pathways, and to communicate pertinent information back to the primary care physician so that they can best manage the patient. Medical calendar of events, we track things such as physicians' appointments, we track annual flu vaccines, whether or not their medications are about to expire and they need to be picked up. Again, it's just a way for the care managers to manage whatever is needed for that person to take care of themselves. We also have at-risk service contracts available, and so we're one of the few companies that's willing to go at risk for our fees based on outcomes. Sorry. So some additional highlights. We have URAC accredited educational programs, so that's a part of our care management. The real-time vital alert monitoring. So back in the old days when I ran a home health agency, we had a person who was sitting at a desk, and as the home health nurses would go out to the home and use a Bluetooth device to take a blood pressure, somebody had to be sitting at that computer so that when the blood pressure reading came in, they could say, okay, Ms. Smith just took her blood pressure, but it's okay, so we're not going to worry about that. But it was one person who was responsible for doing that all day long, for not really that many patients. But the way My Charlie works is we have a very robust dashboarding system with some artificial intelligence behind it that tells us when somebody needs to have an intervention. So we're not having to look and sift through a medical record or sift through pages within the medical information. The system is doing all that for us, and that's pushing out an alert to a dashboard that's telling our care manager, hey, you need to give Ms. Smith a call because her blood sugar was 600, and we must do something to intervene in real time to keep Ms. Smith from having an ER visit or a hospital visit. They're also able to access My Charlie through the website, so they can have access both on their tablet, a smartphone, their computer. They can get into My Charlie wherever is convenient for them. But going back a little bit to the risk stratification, so once we bring folks onto All Health Choices chronic condition monitoring, we then do another internal risk stratification to determine which of those participants are at the highest risk that we think for emergency room or hospital stay. And we do this based on a dynamic risk score within My Charlie. And we're the only company that combines medical data, behavioral health data, and social determinants of health. We combine all of those things into this dynamic health risk score. And so, we may have someone who is a high utilizer of the emergency room. Their blood sugar is fine, but they're not taking their medications other than their diabetes medication. Maybe they're not taking their heart medications. Maybe they don't have transportation to see the physician. Maybe they don't have funds to pay for their prescriptions. So we look at the whole situation, just not the medical situation. And all that's a part of that health risk score.
And a big piece of that health risk score, Juliet, that I'll add is when you think about that engagement, with that risk score being dynamic, what that means simply is as you progress up or down, your risk score changes instantaneously. So if I'm monitoring my weight and I go from one tier to another and I'm lowering my weight, my risk score is going to improve, so I feel that. So when you think about that real-time engagement, that's what society wants today. They want to see value and they want to see progression, or they want to see that they're going the other direction. So when you're able to interact and show them visually real simple, I've gone from a 55 to a 60 or a 55 to a 45, now they can immediately kind of get things back in order in their lifestyle. So you're not waiting on this annual return to the doctor to do an annual wellness checkup and say, well, what have you been doing the past 10 months? You've gotten worse type deal. This is something that's in front of them on a daily basis. So,
Yeah,
well,
I forgot what I was going to add there.
but it is a very effective tool for us. And so, any questions or comments on the chronic condition monitoring program, real quick before we talk?
Matt?
Go Blue Hose.
Go Hose, yay.
How do you get paid?
We get paid from the organization that we're working with. So, of course, none of this is reimbursed by Medicare or Medicaid or private insurance, but we contract with hospitals, with self-funded employers, Medicare and Medicaid plans, third-party claims administrators. So really anybody that's taking risk on healthcare claims, if they have high claims, that, the reduction goes right to their bottom line. And so,
So if an individual wanted to just contract with you, is that possible too?
that is,
Okay.
it is. We do have several people who have done that.
And it's typically a monthly flat rate, so it's not based off the number of interactions that a participant may have. We just have a flat rate for the level of service that you're at. So if you're in that high touch, high feel chronic condition monitoring Juliet just described, that's a higher rate than this lifestyle management solution. So there again, the lifestyle management we're going to talk about, this is someone with chronic conditions, but they're a low utilizer of health care. Okay, so when you think about that stratification, we identify where you're most likely to be aligned with our service model. and then that depends on the rate of the member. And so each one of the levels has various intervention points and touch points. So at our highest level, you're going to be immediate intervention from your care coordinator if you miss an alert, whether it's medication, a vital reading, et cetera. And some of the others, you may be getting a weekly call to talk about how your week was, type deal, as opposed to intervening on a daily basis. So that's a big determinant for us.
Darlene?
Thank you, Mr. Chairman. I have a couple of questions. What is your total number of enrollment right now?
We've got roughly 1,000 patients in the chronic condition monitoring right now.
Okay.
So the solution that Juliet just went through is what we have in patients.
Okay, and you can enroll, from what my understanding, you can enroll part of a group, a whole group. It really would be what's necessary. What kind of incentives do you see are most effective to get membership involvement or to get your patients to follow?
Yeah, so kind of the question is, so either incentives or really I think the question is at the point of adoption and ensuring that you keep the individuals in the plan. So depending on the audience for which we're working, so when we look at self-funded employers, we find it really easy to have incentives. They can do things such as a little bit lower premium charge for individuals that do participate in the program. We've seen things such as other incentives for if you take and improve your risk score from one stratification to another, they give you a little kind of a wellness type incentive that they're giving back to the members. And then from a TPA perspective, we've seen them do things such as just keeping their premiums level year over year. So when you really think about a consumer of health care, my premiums are going up 10 to 12% on an annual basis right now. So when we go in and put this program in place, we've seen TPAs start being able to hold their premiums level year over year. So really, the consumers are getting a 10 to 12% savings on an annual basis because now they're no longer seeing that increase come up year over year. And from the Medicare, Medicaid side, I don't know that they're really providing incentives to the individuals at all. These are individuals that just have been identified that they're not getting the outcomes they need based off of the care plan that they're on. And the biggest incentive for them is they're starting to feel better on a daily basis, and they've got real-time access to a qualified health professional to help them go arm in arm and manage that chronic condition on a daily basis. So it's not so much financial as far as premiums with that population. Now, we have seen their out-of-pocket expense goes down for those members. So ultimately, kind of the outcome of the My Charlie solution for that individual is they now got more money in their pocket because they're paying less co-pays. They potentially see a reduction in the number of prescriptions they're picking up on a monthly basis. So now instead of spending $300, I'm spending $200 type deal. And so those are indirect outcomes financially for those members.
Mr. Chairman, along those same lines, I'm assuming that you've seen that certain risk factors, there's links between cardiovascular disease usually leads to other serious conditions that patients have. Do you base your costs on the patient? I know you mentioned you could do just portion of a group, so you would have just the really sick folks.
Yeah, so-
And again, this is tying back to the cost, looking at what the costs are. I assume you do it by a PEPM?
We do.
Okay.
We have multiple levels of service, and so we have everything from technology only to full chronic condition monitoring. And so the costs range anywhere from about $20 PMPM to about $350 PMPM for the highest level.
Okay.
So if you take the $350 over 12 months, if you're looking at reducing one ER visit, you're about halfway there, or you're there, depending on where the hospital's located. And certainly one hospitalization reduction, you've already exceeded your cost projections.
Thank you.
Have y'all talked to the state health benefit plan or even the CMOs within the state that look after Medicaid? Have y'all had any conversations with them about the chronic population?
We're in active discussions with one Medicaid health plan that exists here in Georgia. Of course, it's the aged, blind, and disabled population that we would mostly be working with. But we are working with health plans in New York, some MLTCC plans, Maine, other states, we have not spoken about the state health benefit, to the state health benefit plan folks directly at this point.
Please.
Yeah,
Clay?
Thank you, Mr. Chairman. Again, please. One of the things that you mentioned that you just kind of went by pretty doggone quickly that I'd like to put a comma at. You mentioned your, how you get paid. And you mentioned at risk. We had a conversation yesterday in this room around this table regarding some of the management companies at hospitals that take their fee off the top, whether or not they're doing a good job managing hospitals. The fee at risk, am I correct in assuming if I contract with you for these employees and I don't get the desired outcome in savings to me, that you don't get paid?
You get a refund of the admin fees that you paid for the difference. So on a monthly basis, we're calculating the administrative fee based off the level of services for the members, okay? And then on an annual basis, we look at the actual claim dollars saved for those individuals within that population. So let's take Juliet's example earlier of the $4,200 annually to take care of me, okay? And so we started in 2018, they're taking care of Dwayne Chapman, and in January of 2019, we look at Dwayne Chapman and we say, hey, he had a $3,400 savings in claims year over year. So All Health Choice then refunds $800 for Dwayne back to said payer, whether it was the plan, the employer, whomever sponsored and paid that administrative fee. So Representative Perkle, you're exactly correct that ultimately, you're right, you're not paying for, if you don't get the savings, you don't pay for it. But it's kind of a you pay and then you get your refund type deal.
You put your money at risk. I appreciate
right.
that.
And that's 100% at risk.
Thank you.
Dominic?
Thank you, Dwayne, Juliet, thank you for your presentation on that. And I know this is the chronic illness portion of it, but in the last couple of days, we've heard a number of presenters mention the fact that top 20% of what we call the frequent flyers into these emergency rooms, and I think that's why this is a part of the conversation with certificate of need in these hospitals that are having to see everybody that walks through the door, and they have these frequent flyers, and that 20% of the population is 80% of the cost of health care that they're having to see time and time again. One of the examples you shared with me was of an individual, which could have been a extreme case, but a person that had been in the emergency room as many as 20 times one year under your service, as a participant in your service, was reduced to one visit. And so the thing that I think would be interesting to hear is how just that one individual and their the value that you've brought to just that one person covers 15 or 20 other people
Yes,
that you may not have reduced as much.
that's correct.
Remembering that as a state, we have these, whether it's the state health benefit plan or the ones that are uninsured on Medicaid, Medicare, or whatever, that we don't separate those people into groups. They're all under the state of Georgia. But could you elaborate a little bit on that example of that individual that went from 20 plus visits to one emergency room visit?
Yeah, and I'll give some commentary around it, and Juliet, you feel free to add if you feel like I kind of get it off. But so what we're referring to there is actually it was a frequent flyer program of a hospital, and it was with the EMS service provider that came to us and said, hey, we've got some problems within these rural hospitals of the frequent flyer program. We think your service would fit in well and start enabling us to better manage them appropriately as opposed to picking them up and bringing them to the ER 2 times a month. And so we put the program in, and just as you stated, we had individuals that were exceeding 15 to 25 visits a year to the ER, and within the first 12 months, they were down, and this individual specifically had gone 24 times the previous year, and actually they've gone 1 time now in 3 years that they've been on our service. So they've gone 1 time in 3 years. So it was 24 times annually, and we're down to 1 in 3. But the interesting thing that you're talking to a little bit about, Dominic, around how healthcare is the The hospital then went to the EMS provider and said, hey, that service y'all put in is great, but the people aren't coming back to the hospital. I need them to come back some so my billing stay up. So it's kind of interesting that, you know, when you look at the healthcare providers, they want to talk about improving healthcare, but they really don't want to eliminate healthcare. And so you've got to find a way to balance that act. And so it's been kind of one of the interesting things that we've seen. And so, and actually I think they really stopped supporting that program, if I remember right, from the hospital level. But we had tremendous outcomes within the population during the few years that we did it. So.
Mr. Chairman, just kind of a follow-up on that. When you mentioned the state health benefit plan, that is what sort of scares me about what this has the potential to do, is because that same hospital that says we don't want that non-pay infrequent flyer says, I do want Terry England. Because, but and so I just think that is a real part of this conversation we need to have with these hospitals. Well, I don't want that frequent flyer, but I will take Mr. England once a month. And so that would be a decision that this committee or even this legislature would have to make if we were able to utilize something like this, because they want to cherry pick too. and I don't think that that's fair.
Well, I think what, in that particular instance, dealing with SHBP, what we have to be mindful of is what our cost is to the state taxpayer. Because it is basically an ERISA. So whatever it costs us to do business this year is what our premium then becomes next year. So we all gotta look after each other, but then sometimes we gotta look after ourselves too.
Yeah.
Let me ask you one question on, you mentioned an individual could take in contract with you for their own care. Say if a child of a parent, that the parent is maybe up in age, still living alone though, and may or may not have some chronic illnesses, but have some things they need to take meds for and everything.
Mm-hmm.
So if the child were to subscribe the parent to the service, would the child then have a way to also monitor and kind of look at, make sure mama's taking her medicine the way she's supposed to and all
Yeah.
that kind of stuff?
So one of the things I forgot to mention was when the alerts come out to the nurse that say, Mr. Smith hasn't taken his blood pressure medicine today, any family caregivers can receive that as well. And they also have access to the data in the app, so they can go in and manage that.
Okay.
So we do have quite a few participants who are in that scenario where they're not ready for assisted living, not really ready for a nursing home, but the family members want to have that daily oversight.
And then when you think about the accountability and engagement, by being able to tie in other family members, we're able to kind of say, hey, my wife now calls me and says, Dwayne, you haven't taken your blood pressure meds. I see that. So that's how you continue to get that adherence rate to go up, as you get as many people involved as necessary to get reaction from the member. So.
Okay. Got time for one more question, Clay.
Thank you, Mr. Chairman. Regarding Chairman England's last question, and getting this for maybe an older parent that is still living alone. My dad has called me before and could not change a channel on the TV. He's still of sound mind, but technology is not his greatest forte. He don't know how to text, and the utilization of this tablet for the older population, are you having difficult times with people like my dad who, if he hits one wrong button on that doggone remote, he can't change channels and watch Gunsmoke or whatever. How are you able to work through that?
I'm laughing because I had that same thing happen to me 2 days ago. My dad couldn't get the sound to work. The app is very easy. It's 6 large buttons. It's all touchscreen, and really there's only 2 buttons they need to use. One is the button that calls the nurse, and the other is the button that connects their Bluetooth device. There are also other features that can be used in there, but they don't have to use them. The other features can be completed by the nurse. But if someone is 45 and fully versed on how to use a smartphone, then yeah, they may want to go in and fill out things on the calendar themselves because they know how to do that. So they're just two buttons that are completely necessary, and the rest is all additional, but the nurse is there to help them if they can't use that.
And
So-
then, and from a member perspective, when you receive an All Health Choice kit, so let's say I'm newly enrolled in the program and now I've got a kit mailed to my home, that kit is already what I'll call synced. So the devices and the tablet have already been connected. You take them out of the box and turn it on, okay? So you're not getting something to your home that you then say, okay, how do I get this Bluetooth device to work with this tablet, and I've got to sync this up. We're already providing the tablet with the Verizon internet that's included in the service. We've got it turned on. So when they turn that tablet on, the internet comes up. They're not connecting the tablet to anything in their home if they don't choose to. And so as Juliet mentioned, it's a really easy to look at intuitive system in that it's push button. I want to take my blood pressure. I push that button, take your blood pressure, put your strip in the glucometer, connects it, says confirm reading, okay, and then that's put into the My Charlie system and the nurse sees it immediately. Okay, so when you look at this, we've got members from 19 to 92. Okay, it typically takes us about 14 to 21 days to get a participant what I'll call fully engaged and starting to utilize the system on a daily basis. And so while there are at times going to be hurdles and participants that may not get it originally, after a couple, 3 weeks, we found that they've got it figured out because it is very intuitive and easy to use, and it's all touchscreen enabled. Participants do have a PIN number, and it's a 4-digit PIN. So that could be their birth year, their birth date, whatever they want to make it. And so when you think about that telehealth call, when the nurse calls them, they put their PIN number in to answer. And so that way, that's kind of a HIPAA deal, so that Juliet's not answering my call type deal. So does that address your question, Representative Perkle?
All right. Thank y'all very much. Y'all
No.
certainly given us something to think about.
We appreciate it, and thank you guys for allowing us to come. And so quickly, I will tell you that we talked high level on the chronic monitoring solution, and then the lifestyle management and disease management is really just smaller components of that chronic program based off of being a lower utilizer of healthcare. So same functionality, just a little less touch points and intervention. So we appreciate it. Thank you all.
Thank y'all.
Thank you.
Terry, that lifestyle management is the one that I need, because in a couple of months, I'm gonna be on that hypertension and blood pressure one right now.
All right, our next presenter this morning is Mr. Carl Zimmer. He is President CEO of Premium Peanut out of Douglas, Georgia. We did hear from Carl last year, and he kind of piqued our interest a little bit, dealing with work-based clinics and what they're doing there at Premium on providing access almost to instant health care to their employees, employee families, and their shareholders there in the cooperative. And so we've asked Carl if he would come back today to talk a little bit more about what the track record has been there, their success, but also give us some ideas if there are things that we as a state can do to incentivize employers to do something similar. Those savings at some point should convert to the bottom line of the employer due to decreased claims on insurance, but we'll see if that winds up happening. But I think, Carl, the jury's still out on that last time we talked, but that's the theory anyway. But Carl, good to have you with us. Thanks for being back with us again this year.
Absolutely. Thanks for the opportunity. And it has been a year, so I'll just take a minute, give you a little bit of update on the business. It's been a good year for the business. For those who don't know us, Premium Peanut was formed in the fall of 2014. And we are essentially a co-op. So we're owned by today 350 farmers in 30 counties throughout Georgia and Alabama. Last year it was about 250 farmers in I think 20 counties. So we've expanded a bit in the past year because I think the model works to create stability for peanut growers throughout the state. And we've had a tremendous amount of success in that because then we also create stability for our customers. And that model has worked very well for us. So if you look at where we're located, we're in, there we go. We're in 30 counties throughout the state. This year we'll handle between 15 to 20% of the peanut crop in the state, including in a brand new buying point, one of our affiliates built just down the road here in Statesboro. So we've grown the buying point base, we've grown the farmer base, we've grown the amount of tons that we're handling. And I think this is all great because it helps us to be more involved and ingrained throughout the state, throughout the agricultural community, and as I mentioned, not just in Georgia this year, but also we've reached out to some other states, and really focused and very focused on how do we add value to the rural peanut farmer throughout southern Georgia. I work for 350 farmers, and we take that very, very seriously in all that we do. How do we create value for them? And that feeds into some of this discussion on healthcare, and I'll get to that in a minute. I do want to mention we're very proud of the fact, a startup business, you often don't know how it's going to perform. Well, we asked 350 farmers to invest with us. As of, the oldest one 3 years ago, we're paying out dividends, and we paid out our first dividend this year. So we're already generating a return. We're generating value for those who have invested in us, and we're very proud of that. Where do we have employees? We're located in Coffee County, but if you look at our spread of employees, we're not just in Coffee County. I mean, clearly, we're there, but we're hiring and we have employees on site at the main shelling plant from 7 counties. And I think this is very important as we think about healthcare, and was one of the drivers for what we've done with the rural clinic, with the mobile clinic that I'll get to in a second. Because if we're bringing in employees from 7 different counties, and they have a sick child, they're not going to be at work that day. By the time they get to the doctor, or they call the doctor, get an appointment, get in to see the doctor, take their child or spouse or themselves to the doctor, get home, they don't have time to come and then drive to Coffee County or to drive to Douglas. It is difficult to attract employees from other counties, though. There's challenges with infrastructure that you all are more familiar with than me. There's also challenges to recruiting employees, and I did want to mention this because it is one of the most significant challenges. I think if you asked our local hospital, the CEO, and she and I had a discussion on this the other night, what her challenge is, it's recruiting physicians to come to the rural hospital. So I wanted to share a real life example of a recruiting scenario that we went through over the past year. We wanted to hire an engineer, a young engineer, and convince him to relocate to Coffee County, to relocate to Douglas, and to come on board with us. We worked with him for over a year. He's a young engineer, has a young family, so we got him there, and I'm excited. We got him. He agreed to move. They moved to Coffee County, and then he comes in my office one day, and he said, Carl, I have a serious issue. I can't get my kids in school. I said, what are you talking about? You can't get your kids in school. And he goes, we can't get them in the schools they need, and my youngest one, who's in pre-K, I can't get him in any program. And I said, yeah, this has to be some kind of joke, right? So I go start making phone calls, and I called the superintendent, called Representative Laricia, called a lot of people. The first 5 people said, you're right, sorry, we can't help you. It's too late. We have an open enrollment school system. I'm not sure I'm using the technical terms. The application process to get in the schools started and really concluded 5 months ago before the last school year ended. So you're too late. He's stuck. Come back and talk to us next year. And no, you didn't say that. Thank you. Dominic did not say that. The first 5 people I called said that. That's discouraging. Now, we worked through it, right? We got the one kid who had some special needs, the one child who had some special needs. We got him in the school he needed after some heated conversations. The second one's in pre-K, and I don't know all the details of it, but essentially, as I understand it, it's a state-funded program with state limits set on the class size. And if you're not in the county at the right point when those classes are filled, you're out of luck for the next year. And so a lot of the work that I think has come out of this group with the tax incentives, et cetera, to encourage people to move to these rural counties is absolutely phenomenal. But if I have an engineer in my office saying my wife's ready to leave because we can't get our kids in the right schools, or we can't get our kids in the schools that they need, all the tax incentives in the world don't matter. So I just wanted to raise that because I think it's incumbent on all of us into, once we get those people, once we get that doctor, once we get that engineer, once we get somebody and convince them to say, yeah, we're going to make the move, how can we make that move easier? Because 99% of the people in the county don't have to deal with that. We don't have a lot of people moving into Coffee County. So how can we create that right environment? How can we create those incentives? How can we create those exceptions to pre-K class sizes, et cetera, so that when somebody does move, they're essentially not stuck waiting a year before they can really get involved in the community, get their kids in the right schools. One of the other things that we've done is we've expanded into peanut oil. So now we're continuing down that value chain. It's one of the reasons why I'm recruiting engineers, because we've essentially built a chemical plant. Peanut oil, it's very similar to a chemical plant. It's a closed loop process. You don't see very much if you go into the plant. You'll see a lot of pipes and tanks and control rooms and things like that. But we are producing peanut oil now as well. And so we're very proud of continuing to add value to the product for our shareholders, our farmers in rural Georgia. But we're tapped out. My ability to grow further in Coffee County is really hindered, and it's significantly hindered, by the availability of a trained, skilled, and stable workforce. And I know that's a lot of the things that this group and we're all dealing with, is how do we get that trained, that skilled, that reliable workforce? And one of the things that I believe we can do is directly attributable, directly linked to healthcare. Why? If you look at my separation rate, and I hesitated to even share it because the numbers aren't pretty in terms of the number of separations that we've had on a monthly basis. Oh, let me get to that slide. Yeah. There we go. Year to date, we've had 70 separations, which is about a 30% annual turnover in the plant. 30%. And that's actually better than a lot of my fellow CEOs or fellow businesses in the county. 30% annual, and that's through 8 months. So by the end of the year, we're going to have 40 to 50% turnover. You know, whatever the cost is it $500? Is it $1,000? Is it $5,000 to hire, to recruit, hire, train, get up to speed these employees, and then you're losing them after sometimes a very short period of time. 50% annual turnover is too much. A lot of it is because of failed drug tests. We're not unique in grappling with that. We do, and we're mandated by a lot of our food customers to do random drug testing. Every time we do random drug tests, we lose several people. Absenteeism. And absenteeism is something that healthcare, and one of the things we're doing with this clinic, is hopefully going to help solve, and performance issues. So what are some of the things that we've done to try to offset that? Well, we can pay, and I think we pay well. We pay above the average in the county and the area. We offer opportunities for overtime to give people additional incentives, and that's all great, but money's just the first primary level. Everyone needs to make a good income and be able to live. We're very focused on skill enhancements, and I will put a plug in for Quick Start, which is through the state of Georgia. It is an absolutely phenomenal program. We've used it twice now. Absolutely phenomenal. We do development courses. But then how do we give people an opportunity to use all of that to their benefit and the benefit of their families? We've had 32 promotions, which is about 15% of our workforce has been promoted this year already due to skill enhancements. And because they've taken the initiative and we've provided them some of the opportunities using a lot of the resources like Quick Start, we've been able to promote employees, give them more responsibility, give them more money. And we're very proud of that and giving them an opportunity to really have a career. We also provide good benefits. We have 401k, we have 401k match, and yes, we do have medical insurance. Our annual cost per employee is $3,800 for medical insurance. $3,800 is what we've paid over the past year. and that's the cost for mainly for insurance, right, in our portion of insurance. But all of these things are not enough to keep employees. We're doing all of this, and we still have 30 to 40% turnover, right? So how do we go about reducing that rate of attrition, reducing that rate of turnover? And really, that was our biggest driver for the investment that we made and the partnership that we made with our local hospital in the mobile clinic. It wasn't to reduce healthcare costs. It wasn't to reduce our insurance premium. It was something that we felt we can do for our employees to give them the incentive to come to work for us. And if somebody down the street said, well, I want to offer you an extra 10 cents or 25 cents an hour, to give them pause and say, well, wait a second, right? I have something here that's an intangible benefit. It's not cash, but it's an intangible benefit. Maybe I won't go down the street and take another job. Or maybe I don't really want to lose this job if I'm close to, pointing out. We assign points if you miss days, right? If I'm close to pointing out, I don't want to lose this job. Because yes, I can go down the street and I can get another job and I can probably get the same pay, but do I get some of the benefits with it as well? And so what we've done is we partnered with the local hospital, and it costs us $4,200 a month, which is a base fee, and we have a mobile clinic on site at Premium Peanut. It's open 2 hours a day, Monday through Friday. It's staffed by a physician's assistant or nurse practitioner and a receptionist. And if you're an employee, if you're a family member of an employee, and that's defined however you want to define it, right? We're not going to turn you away. If you're an employee, if you're a family member, if you're a shareholder, or if you're a member of a shareholder's family, or even if you're affiliated with some of our buying points, you're welcome to use the clinic. 2 hours a day, there's no appointments, there's no insurance, we started out with a $10 fee, now there's no fee. So it's 100% free. You walk in, what do you need? And it's worked very, very well. Not just from providing employees access to health care that's simple, that's easy, that's cost effective, but back to how do I make their lives easier? How do I reduce or create incentives for them not to miss work? You don't have to miss work now if you have a sick child. You can bring him in the morning. Maybe you'll be an hour late. That's better than missing a day. You can bring him in. You can have him seen. You can get the medical taken care of. You can take the child home and come back to work. And that's what we'd like you to do. We want to create these opportunities, yes, that you have access to health care, but back to how can I reduce that turnover rate? How can I drive more incentives for our employees to want to work for us? And that's why we did it. One of the things that we have done is the $10. To me, and sometimes, it's easy to get out of touch. But we said, let's do $10, just to have somebody, just a basic nominal fee for somebody to pay. And finally, a couple of people came to me and said, Carl, it's too much. It's too much. They said that is hindering people going to the clinic, right? They'd rather wait until they get really sick and hopefully they get over it, or they get really, really sick and they go to the emergency room and get indigent care, et cetera. They said the $10 is too much. Do you think we can waive it? I said, absolutely, right? I mean, it was really just a way to have a nominal fee there and to have them feel like they're part of that process. We waived it, and the results have been pretty dramatic. We didn't waive it. I'm paying. The company's paying it now, right? The results have been dramatic. Just the $10 made a lot of people stop and pause before they came to that clinic. If it was truly something that wasn't critical need. They said, you know what, I'm going to wait and see if I can save that $10. So, that really opened my eyes, and it's an unfortunate situation, but we're all dealing with it, that we have, challenges with income. We have challenges with poverty, et cetera. And when you think about it, $10 means a lot to people, and it meant a lot to people, made a difference between them coming in and getting essentially otherwise free medical care and not. And so we ended up waiving that, and that has worked very well. So what are the benefits? and this was part of the discussion last year, is what's the return? I'm not sure I can give you a return. I'm not sure I can do that. You know, all of the things that I've talked about instinctively, I feel like are making a difference. When I'm talking to employees, and I've had several of them tell me, I came here because of that mobile clinic. I came here because I know when my kid gets sick, I'm not going to have to miss work. I'm not going to have to put my job at risk. I'm not going to have to lose out on earnings because of that mobile clinic. I came here because I want my kid to play sports, and I really can't afford to take them to a doctor to get a sports physical. Well, you know what? They can bring them to the clinic now and get a sports physical for their child to play sports at school. And so I've had a number of people say that, right? And if they approach me with that, there's more out there. That's one of the benefits. What else do I believe it's done? I believe it's reduced absenteeism. I don't have numbers on that because I can't tell you, how many have not missed work because they had access to it. Has it reduced my medical costs? I'm not sure. We did a partially self-funded plan last year. We're not doing it again this year. But we did a partially self-funded plan with the idea that if we provide early care, we'll reduce our overall health care costs. And I'm sure if you look at by employee, you could say, okay, well, these ones last year had so much in claims, and maybe they used the clinic once or twice, and they had reduced claims this year. That's all great, but essentially, I didn't save anything because of it, because we had one chronic case of cancer, unfortunately, that wiped out all of the potential savings that we could have had. So my self-funded plan, partially self-funded plan, we hit the max on it, and essentially I didn't save anything. Are we still going to do the clinic? Yes, we are, because I still believe that there's benefits there. But how insurance programs are structured today, if you do the self-funded or partially self-funded, you could save on an individual by individual because they've used the clinic, you've caught care, you've caught issues early. But if you have that one chronic case or the two chronic cases, then all of those savings are gone, and it really doesn't matter to your overall cost. And I think that's one of the challenges we've had, and I've challenged our insurance companies and the brokers we work with and everything else, is how do you structure something where if we're doing the right thing, I believe it's the right thing, we're making an investment like this, how can I return to my shareholders some hard dollars on it? There's not a way to do it today. Unfortunately, there really isn't. Yes, I think we're also reducing ER visits. And the hospital CEO, when I shared this with her, she said, well, I'm sure we've seen reduced ER visits. Yeah, but ultimately that doesn't cost me as the company. Now, am I doing the right thing for healthcare costs in total in the state? I think so. But as a company, I'm not seeing any benefit from the reduced ER visits. I already reached my max on insurance, or if I'm not in a self-funded plan or partially self-funded plan and I'm in a, just a straight cost plan, it doesn't impact me this year if they go to the hospital emergency room or not. But I believe it does reduce time and frustration at doctors' offices. I believe it helps with the local community where there's a backlog, a waiting time, a backlog to get in and see a doctor. If I can now take 2 or 3 or 4 or 5 people out of that system every day and help the local physicians now focus more on the ones who truly don't have other opportunities, I think that's a good thing to do. We've tried, and not every day, but most of the days it's staffed by somebody who is bilingual. That's a challenge for our Hispanic community. When you go in to see a doctor, and I saw it when I'm sitting in the waiting rooms, and they're trying to communicate English to Spanish, it's difficult. And the next time, they're not going to go to the doctor. They're going to wait till they're sick, and they're going to go to the ER. And so I think we're helping with that. But it's back to, and this is, I think the message that I've given to others when they say, how do you justify it? I'm lucky that we have a tremendously supportive board and tremendously supportive group of shareholders who want to do the right things. But if you don't have that desire to do the right thing, an investment like this is difficult. And you could say it's $100,000, but I mean, $100,000 is a pretty significant investment for us. So I believe we're doing the right thing, But I would ask all of you to consider as you go through these deliberations, how can we move it from these nebulous benefits, from the benefits that we get inherently from doing the right thing and hopefully having greater attraction for employees, hopefully reducing employee turnover time, hopefully making our employees healthier. How can we establish some more direct benefits to encourage companies like us and others to do the right things, to make these type of investments that day one or year two, you may not see the direct return off of? I don't have the answers to it, but hopefully, through this process, you all will be able to come up with some of those and help these type of initiatives, which I believe are truly the right things to do in rural Georgia. Thank you. Yes, sir.
Couple of questions I think that the members of the committee will have, and I'll start out with asking you a couple. Now that you've waived the $10 fee, is that still, the employee doesn't pay it, but are you still paying that to the hospital?
We are. We
So what's your total cost per month?
It's close to $100,000 a year.
Okay, then my next question is that, what happens to this mobile clinic the other 6 hours every day? Does it go to other plants or businesses in the community?
It has started to. As this has caught on, it's still primarily housed at our location, but now they're using it for health fairs and things like that at other locations.
But I mean, are there any other businesses like Premium Peanut that says, hey, that's a great idea?
No,
No.
not yet. Not yet, hopefully.
Okay.
It's hard. It gets back to if you're under budget pressures, it's hard to justify saying, well, if I've already budgeted my healthcare costs, I'm already paying the max on insurance. Why am I going to invest another $50,000 or $75,000 or $100,000 in this?
Darlene?
Thank you, Mr. Chairman. How many total participants do you have at the company that are using the clinic?
We average, I think it's 2 to 3 a day. And
That
so,
they're 2 to 3 a day are going to the clinic?
Mhm.
How many total do you have? I'm looking at, you're spending $4,200 a
Yeah.
month. How many members do you have?
we have 230 employees.
Okay. Have you looked at any of the data to see, stratifying it? What are they using the clinic for? Are they doing, I guess it is, what all are they doing at the clinic? Is it somebody just for a physical? Is it a flu shot? Are they kids also participating? Those type of things. Are you stratifying to look at how it's being utilized?
We are, and it's all of the above. The main one is for allergies, sinus infections, sore throats, those type of things. Where
The number of visits per month, again, you're looking at how many, you have, I think it was 7 or 9 counties that you're in. Will this vehicle move from county to county?
it does not.
It
No,
stays
does
right
not.
in your county?
Correct.
Okay. All right, thank you.
Ed?
Thank you, and thank you, Mr. Zimmer. This intrigues me. We've been talking about soft skills almost since the beginning, and a lot of your problems is what we've heard in other places, regardless if they have a mobile clinic or not. You referenced failed drug testing, absenteeism, and performance as the key indicators for the reason for your turnover, and then you later said that they may leave for 10 cents or 25 cents an hour. What percentage does that?
I think they're related. I don't have the exact percentage, but in my mind, they're related. They may, if they know they can go down the road and get a job tomorrow for the same price or maybe 10 cents more an hour, then they're not worried about missing work today if they have something else going on. So they'll take the absenteeism point.
And I guess my point was you use those as the main drivers and then reference this.
Yeah.
And I didn't know if that's that part of the pie or if you could tell us if that's 50% of your problem.
I can't, because I think the ability to get another job or for the same price or 10 cents an hour more is the secondary cause. It manifests itself to me in absenteeism and those type of things, because they're not concerned.
And when you dropped your $10 for a visit, what percentage increase did you see in the number of visits?
We just did that about 2 months ago, and I think it's up 30 to 40%.
do you have a way to, you don't want people not going because of the $10. What is your policy when someone says, I don't feel good and I need to go to the clinic?
Well,
You can lead a horse to water, but you can't make them think, and people are going to game the system, you know that?
yes.
How do you monitor that?
We really don't. No different. I'd rather them say, I need to go to the clinic and take 5 minutes than I need to go to my doctor and I'll get a doctor's note.
And then just finally, from your own business model, I'm curious, representing Worth County, the largest, the home of the Peanut Festival. And Mr. Chairman, Mitchell County as well, and Ms. Chairman, Decatur County. We have a lot of chairmen here who actually represent 5 of the largest peanut-producing counties in the state. And yet, it looks like your model is moving to the east and not to the west. Have you looked at penetrating?
We have a buying point in Thomas County, Meigs, this year as well. So we're also moving to the southwest.
Okay, very good. Thank you. Appreciate it.
I was there last Wednesday as the first loads were graded.
Great.
One quick question. Who
Penny?
owns the mobile unit?
The hospital does.
Thank
Yeah,
you.
Coffee Regional Medical Center. And they also staff it. And essentially, I think if you asked on the cost, it's really an investment for both. They're not making any money on it. That what we're paying is we're essentially covering their fixed costs and depreciation and all of that on the clinic. And so it's really been a leap of faith on the hospital's part as well to say, you know, this makes sense, and can we use it to try and generate some momentum? And I think we're starting, but there's a long way to go.
But the employees in there are hospital employees?
Yes, sir.
Okay. Rick?
Yeah, thank you. This is a great program, and see it used in a lot of places. As a practical question, what are the hours? And what have you found the
Yeah.
most effective hours for you?
We do 7 to 9 a.m. Our
7
shift
to
changes at 7, so people coming off shift can get home if they have a sick child, bring him in, or if they're sick or their child's sick, they could still come in the morning, see the clinic, and be an hour or 2 hours late to work.
Gotcha, okay, thank you.
Dominic?
Thank you, Carl. I was just talking to Representative Taylor, and it is hard, the same way that you mentioned, it's hard to share specific benefits that come from this, and being able to quantify dollar value. But I think what Chairman England mentioned is about how we were just interested in this. The true value of this comes with the potential that comes with it. Because of workforce development and turnover rates and trying to keep people employed and providing access to health care. Like you mentioned, they didn't even want to pay $10. So is there a way that you could maybe survey your employees with just a little short survey that would say, hey, have you used the clinic? What was your experience? You know, because it would be beneficial for us to be able to show other employers
do
in
that.
Coffee County, particularly to use that clinic, but across the state to be able to offer a shared investment in this. Instead of everybody paying $100,000 a year, several employers could pay $5,000 a year and start to survey employees to track reducing absenteeism, to track limiting visits to the emergency room, to the hospital, and that kind of thing. You think, would that be something
Yeah, no,
that we could?
we absolutely can do that, and we should do that regardless.
Right.
And I think we're probably at the point of critical mass, and you say, okay, 2 or 3 people a day using it, but you know, 5 days a week, you're talking 60 people a month. That's a third of our workforce almost, or a fourth of our workforce is using it, or a family member is using it. So we can do that. It was also interesting for me, I'll mention it, that no one believed us when we said they're not going to take your insurance card when you go in, or they're not going to send you a bill for a lot of money after you use it. That's been the biggest hurdle for us, is convincing employees to say, no, we're serious, right? It's free. And you don't have to give them your insurance card. And you don't have to worry about getting a $500, $100, or $200 bill, after the fact from insurance that you're going to have to fight with. And that was just so incomprehensible to so many people. And so we're doing things like, if you go to the clinic, you'll get a raffle ticket and we'll raffle off something, once a month and all of that. I'd rather have people just go in and say, I don't feel good, and give me my raffle ticket to drive that, the usage, so that when they truly are sick, they think about it and they're not hesitant or fearful to use it, because they've had so many bad experiences with, I go to my doctor and I think it's a $20 copay and then I get a bill for $500 type of thing.
Carl, is there an issue with the old adage about no good deed goes unpunished, as far as any increased liability on the company? You provide that service and somebody gets bad medical treatment and they sue you for it? Is that a concern?
I'm not saying maybe it shouldn't be a concern, but it hasn't been. It hasn't been, because it's still, we're still, it's technically, I guess, we're not paying for that associate. The hospital's giving us a bill, at the end of the month, saying we saw, 10 employees, and so, the bill's $100.
Right, but I didn't know if there was an indemnity agreement between the hospital saying, those are our employees, and so we agreed to cover you in the event of any kind of.
Yes, I believe that's part of the contract and the agreement we have with the hospital. Sorry.
Anybody else? Bill?
Thank you, Carl. Not only for your innovation in the medical, but just everything y'all have done. I've shared your story with many a person because it's just incredible. And this might be a question or comment for the two chairs, since y'all are the gatekeepers of the money, to throw in with all the ideas we've been given. A tax credit for to help smaller
I was thinking
businesses do
about
the
that. I was thinking about that, Bill, but since they're co-op, they don't actually pay taxes. So we would have to come up with some other way to incentivize at least a co-op to do it.
Okay, but like, because I was going to bring up what Dominic said about the smaller companies.
But
For
we
some
could,
incentive.
but thinking back on that, there are tax credits that we've got that you can take against payroll taxes.
tax.
Okay.
And
Yes, sir.
that could be a possibility.
Okay, because like I said, just congratulations on everything y'all have done. Thank you.
Mr. Chairman, in that regard, we've gotten a little pushback recently from some of the mobile dental, because their argument is if you look at incentivizing one way, which is trying to create access, you're actually, the unintended consequences may be that you've got dentists in rural areas that go, you've taken away a little bit from my patient pool, and so therefore you don't have an incentive to land primary care physicians or dentists or things of this nature, because you've also created almost to a certain extent amount of competition with that incentive. And we've heard that in Southwest Georgia with those mobile dentists. So I just want to think that we have to make sure that we look at this in a big, broad picture. We don't want to do anything that doesn't create a reason for people not to want to come and practice in rural Georgia as well.
John?
But I would add on that, though, if you're talking about an individual that's not willing to pay $10 to go to basically a free clinic, you're more than likely not going to be talking about that patient anyway going to a primary care doc.
And that was the exact argument I used with that group of dentists.
Okay.
But they're just saying, what's happened is you're going in there to that school with these mobile dentist labs, and now what happens is, now that since that happens, they don't come and keep their appointment.
No, I see what you're saying.
So that you're just trying to find that balance to access and not having the unintended consequence.
John?
Thank you, Mr. Chairman. Thank you, Carl, for your presentation. I want to expand a little bit on what Chairman Powell started out with about other companies possibly doing this, and if you could partner with other companies to keep it open longer hours, they could see it for 8 hours a day possibly. You do it, Walmart distribution, Diamond Trailer, Destiny Homes, might be a possibility. Just a comment, not a question.
Absolutely, and it's we started, actually the hospital CEO started our CEO roundtable and forum, and this is, we've talked about it. Part of it is just getting it to the top of the priority list for anyone to look at, right? You know, all of us are dealing with 100 different things. And until it becomes critical, it's difficult to get somebody to say, okay, I'm gonna take the time and figure this out or make the investment. I think it was critical to us in large part because as we're new and we're starting up, so I need to attract employees, right, that others already have some. I want to retain them, and as we continue to grow, I need some other recruiting tools. But I absolutely agree, and it's something that we can and should spend more time on.
All right, last question, Darlene.
Thank you, Mr. Chairman. I'm trying to get a hold on the mobile part. I get moving place to place. I've seen the success of rural communities. I know in Coolidge, we have an employer that actually has their own on-site clinic, and they do great. They have a lot more participation, and they have set hours. They have regular electronic medical records, and it technically becomes the medical home for primary care, whereas I worry that this will be like a temporary, it's almost like a floating ER room or something. Does it help coordinate the care of the employee? Again, that's what I'm looking for, continuing care, consistency, making sure they're following some of the things that we saw from our previous. We want somebody that's going to tie it all together. You may have looked at it and considered it may have cost a little bit more, but you would then say we're open every day from 8 to noon, or on certain days it's noon till 5, and you can get a better coverage for the folks. And again, 2 hours, two patients, it's tough to justify it numbers-wise, whereas this other, it may have been a little bit more, and it works wonderfully. They also can dispense some medications. Again, you've got a medical home, you know they need hypertensive care, so they take their medicine there. But it's a great idea to have it bringing the healthcare to the plant, particularly when you're in the middle of a rural area.
Yeah,
Thank you.
and it's something that, you know, as we've gone through this, you know, we're meeting with the hospital every few months and talking about different ideas and how we can expand on it, because it's not, the clinic does not provide a medical home, as you put it, and I think that would be extremely beneficial and something for us to look at. I agree with you too that whether it's on site or whether it's in a clinic, having it there is so critical. A number of our employees don't have transportation themselves, right? They're carpooling or somebody's dropping them off. And so even if they have to go down the street, they're not going to use it if it's not physically on site.
Carl, we appreciate it. Thank you very much.
Thank you.
All right, our next presenter is Tony Marshall, who is the president and CEO of the Georgia Healthcare Association. And he's going to come talk to us about telehealth for nursing homes. But before he starts his presentation, we have a special occasion today. One of our members is celebrating her birthday, Patty. And so let's wish Patty a happy birthday.
Mr. Chairman, I think our vice chairman is still getting over his from 2 days ago.
Okay, Tony.
If I may, Mr. Chairman, Tony asked me, my name is Russell Carlson. I'm a Vice President for Government Affairs here at GHCA. Just to give just a comment or two before Tony dives into his presentation proper. Mr. Chairman, Chairman England, Chairman Powell, members of the council, we're very appreciative. This is a very timely conversation to be discussing telemedicine in a skilled nursing facility. In fact, talking about doing things when no one's looking to show that it's a priority for us. We hosted all the CMS Region 4 states in Atlanta this May, and the priority there, what they led with, what they spent the bulk of their time with was telemedicine in these facilities. We realize, like the speaker said yesterday, that now's the time for innovation and forward thinking. We're highly motivated to do that because we have some interesting things coming our way, and you might want to let this sink in. For 2030 population projections, and Chairman Cooper's heard us say this before, Georgia is first in the Southeast for the 85 and older population by 2030. We're second only to Florida for the 65 and older population. And I know this is a rural council, but bear with me here. Forbes magazine has rated Atlanta as the fastest aging city in the country. So for our profession, for long-term care, we have to be popping on all cylinders by the time that comes. Workforce development is interesting coming on the last day. You've heard it across peanut companies, hospitals, everybody. Workforce is the #1 priority, and we're no exception to be prepared for that. Reimbursement and staffing, but also innovation and best practices. How can we be running on all cylinders by the time this population comes our way? Medical journals and journalism have pegged an interesting little phrase for that phenomenon. They're calling it the silver tsunami. So how do we prepare ourselves for the silver tsunami? And with that in mind, thank you again for letting us be here, and I'll hand it over to Tony.
Thanks, Russell. Mr. Chairman and the members of the council, thank you for this opportunity. Russell set the stage. We met in May of this year with Secretary Renee Elmers, who is the Region 4 Director of HHS. And during that presentation, or during that meeting with her, she wanted to talk about our priorities, and we hosted all of the state execs from the long-term care associations for Region 4. And we wanted to talk about some of our priorities of regulation, but she also wanted to talk about HHS priorities. And so much of what you're going to see today is an excerpt of the presentation that was made during that meeting. One of the things I've learned in the association world is it's not stealing. It's actually utilizing the best practices from other folks. And we're using this presentation today, much of this presentation, as an excerpt from John Whitman, who's with the Wharton School at the University of Pennsylvania and the Trex Institute. They've been working on telemedicine, telehealth issues for a long time, and they've been involved in some studies that we'll actually use in this presentation. I appreciate the fact also that you have Dr. Sumner coming up after, because she certainly is involved with our centers and leading the way in Georgia in the presentation, so, and works with our clinicians on staff as well. We heard a lot about all of the telehealth, telemedicine issues yesterday. Well, let me just mention one other thing. Renee Elmers also met with the Georgia Chamber of Commerce just a few weeks ago. And during that presentation, she emphasized to the entire chamber membership that was present at that HHS's priority, one of their priorities is increasing access to medical care, particularly in rural areas, and that telemedicine will be one of their key components of the strategy for HHS and particularly for Region 4. These were the objectives that were outlined. One of the things I'll do is I'm going to skip a few of these slides as we're going through because they were really focused on that day's meeting, but I will talk about that. Really, you had a couple of key questions for us, and those were, where's telemedicine being used? What are some of the barriers that are in place as today? Basically, what is telemedicine? And you heard it talked about yesterday. Telemedicine means a lot. Telehealth and telemedicine mean a lot of different things to a lot of different people. You can have what we call the store and transmit or store and forward technology, which is telehealth, monitoring blood pressure, weight, blood sugar levels, cardiac monitoring. You heard a lot of those things in the earlier presentation this morning for individuals. And then you can also have the services that are really telemedicine related, which are going to be live streaming, care provider over a distance through the use of telecommunications technology. The telehealth services, as I said, are typically store and forward. Medicare and Medicaid don't cover the store and forward types of technology as a reimbursable service. But the telemedicine portion is actually reimbursed, and we'll talk about those details as we get to that. Just a little bit about the skilled nursing population in the country and then in Georgia. There are over 15,655 nursing facilities in America. Over 11,000 of those are in urban areas. 4,300 of them are rural. 70% Medicaid reimbursement. And most of the studies show that physician presence is limited at best. And there's 2 to 3 hours per week in the rural centers, and that the majority of the care decisions actually get made over the phone. That's really one of the reasons that telemedicine can be so effective. Now, one of the things I want to make sure you understand, my background is reimbursement, and I can do math. So any of you that look at this in great detail will see that we say there are 366 centers, there are 349 Medicaid centers, and then we come right below it and we say there are 345 in urban or rural settings. I recognize those numbers don't add up, and I want to explain why. First of all, the data that we have access comes from the Medicaid cost reports that are provided to the State Department of Community Health. There are currently 4 inactive centers that are either going through renovation, construction, or temporarily shut down in certain areas. So that's how we get to the 345 centers. 73% overall occupancy. First of all, 207 of those centers are in urban areas, 138 of those centers in rural areas, as defined by your definition of 40,000 population. 73% occupancy for Medicaid overall, but you will see that the rural nursing centers have an 80% Medicaid occupancy. And I'm not going to really spend a lot of time today because I want to get into the telehealth, but I did want to just sort of provide for you some of the big challenges that we have and that are happening with this increase in the population. The patients are sicker today. They leave the hospital sooner. We're not of centers today that are caring for residents that are typically all ambulatory and are able to, but they require higher levels have higher levels of acuity and require more services. Lower reimbursement. I'm going to give you a lot of great credit because you provided a significant increase in funding the last 3 years, which had not occurred in Georgia centers for about 6 years prior to that. So I give you a lot of credit. We're seeing the impact of that. You heard it from everyone else. Mr. Zimmerman said 30% turnover. Our average turnover rate is approximately 100%. We would stand on our head in excitement if we could get down to a 30% turnover rate. And Chairman Cooper, you talked about it at great length yesterday. When the economic development of Georgia is so robust that effectively every time there's a new warehouse job that pays $5 an hour more, and you can have a job that frankly is not necessarily as hard as caring for individuals, they make the changes for $5 an hour. Census is down nationally. There was a study that came out this week from National Investors that actually said census is down across the country. We see that here as well. Increased oversight and compliance issues. We saw the most radical increase in regulations 2 years ago from CMS. Clinical outcomes now matter. We're rated and we're paid based upon clinical outcomes. So there are penalties associated with not reaching the clinical outcomes we need, and rightfully so. Families and residents have increased expectations. Again, baby boomer population wants more. Litigation concerns are always there. In Georgia, particularly from the out-of-state litigators that tend to spend a lot of time advertising in our state. And workforce, clinicians, nurses. Georgia has a significant struggle with having RNs willing to work in nursing centers, amongst the lowest in the entire Southeast. We compensate by hiring more LPNs, but from a quality perspective, it doesn't meet the needs that we should have to do effective telemedicine. And from a quality measure perspective, it doesn't meet the qualifications that CMS expects from us in the ratio of RNs in how they measure our quality. There's sort of a default factor today, and that's the telephone. Medicine is provided over the phone, and so we do not have the skill set to effectively differentiate which nursing facility residents need to be sent to the hospital and which residents can and should remain and be cared for in the skilled nursing facility. Some studies have shown that 60 to 70% of all skilled nursing facility transfers to hospital for hospital admissions are not necessary, that they could have been cared for in the centers. That obviously gives us great opportunity to improve the quality of care being provided to those residents. One of the things I will point out, rehospitalizations has been a key focus of Medicare over the last several years. And beginning October 1 of this year, skilled nursing facilities will actually be paid or penalized if they are not achieving the appropriate quality measures in rehospitalizations. And that is an up to 2% penalty. We've heard about the readmissions into hospitals, and hospitals having been penalized. They've now added that criteria for payment to nursing facilities as well. So when we look at, yes, yes.
Are you going to be penalized because you put them in the hospital when they don't need to go?
That's correct.
Okay, because it sounded the other way. Like
No, I'm sorry. That is correct. Effectively, the centers have been have a goal of a specific quality measure that they should achieve. There are two ways they look at it. One is an overall rehospitalization rate, and the second is what is the change from a base period until your current rehospitalization. And they use a formula that determines whether you get, they take 2% from every nursing center, and then they give back somewhere between 0 and slightly greater than 2%. So you actually, if you have reduced your rehospitalization rate effectively, you actually can earn an incentive. If you're not achieving the results that CMS expects, you will lose the full 2%.
And is this just tied to patients that your residents had been admitted to the hospital? Is it just tied to those they've had to have a hospital admission, or is it pertaining to all of them?
It pertains to the percentage of your residents that went back to the hospital and were readmitted.
After a hospitalization.
That's correct.
Mr. Chairman, I got a question.
Getting them both ways.
Sir, is there a way to find out which nursing homes, particularly in my district, have been affected by this readmission to the hospital or this?
Yeah, we don't have detailed payment information, but I
Okay.
can see if we can find out what the actual, each center is given an individual percentage of payment that they're going to receive.
Mm-hmm.
And so the notice for that just came out just less than a month ago. And so it's a published, CMS publishes the methodology in the Federal Register, and then they send to each center the results of their quality measure, and that's not a public document.
Okay.
But you can look at and determine rehospitalization rates from the Medicare Compare website. So there is a public way to look at the rates and the quality measure, but the actual payment amount is not a public document at this point. But we could probably find that out.
Okay, thank you.
Obviously, the greatest impact of telemedicine and the benefits of telemedicine and is to improve the quality of care the residents receive. And some of the benefit, some of the risk that seniors would have by being admitted to the hospital and transmitted: increased morbidity, increased confusion, incontinence, skin breakdown, more medications and not being coordinated, and exposed to hospital-acquired infections. And effectively, you have a significant increase in cost to the system. Now, we'll talk a little bit later about whose cost that is, whether it's Medicare's cost or the state's Medicaid program that's going to benefit the most, but you do have that increase from managing those risks. Effectively, the goal for telemedicine for most centers is to be able to differentiate the resident that truly needs rehospitalization rather than to be able to be cared for in the center with proper orders and treatment. It requires the use of an interactive audio-video telecommunications system that permits real-time communication with the physician at the distant site and the resident at the originating site. And again, as I mentioned, the store and forward technology of monitoring health is not covered by Medicare nor Medicaid. This is just sort of a normal way that most telemedicine services work. The nurse is going to call and connect directly to the telemedicine physician or nurse practitioner on the other end of the phone. That clinician is going to examine the patient utilizing the telemedicine unit and discussions with the resident and the nurse in the center. They're going to provide their notes and orders. We say on here faxed, obviously emailed, and they have to be fully HIPAA compliant transactions, both the communication by video, audio, video, and the actual orders themselves. And then the clinician will additionally communicate with the resident's attending physician and treatment plan, the results of the episode and the treatment plan with the family as well. One of the things that we found is that telemedicine at its core will actually improve access to care in both an urban and a rural setting. It is a cost-effective way of focusing both advanced and preventive care. Primarily, it's an early detection. We can monitor, monitoring will allow the SNF to focus on the residents before they require rehospitalization, which is the key. And it talks about a limited workforce to be virtually present when needed. I think the key point there is we have access to the physicians and the workforce when needed by an actual examination rather than by telephone. Some of the things that physicians have said as parts of the studies that were done and looking at it, they have questions about how it will impact their billing. Does it increase their liability exposure of dealing with individuals at a distance? What's to keep the virtual physician from stealing their patients? All of these are concerns that have been expressed, and the studies have shown that the success of telemedicine is critical to have the buy-in of the physician community to truly be effective. I'll talk about some of the barriers initially, and then I'll focus on some of the recommendations. And one of the things you're going to hear me talk about, I've heard you talk about. During session, I heard you talk about it during your meetings last year when we were there. And number one amongst that is the need for a consistent internet access, broadband access. The need to access IT technical support services. We'll talk about the specifics of what that means in just a moment. But that's more than just having to deal with the broadband. There's more to it. Having full support from the nursing home administrator, director of nursing, and the medical director and the physicians is critical. And then needing support from all of the attending physicians that are caring for the residents. And if you don't have all of those elements, it's very difficult to get the support to have an effective program. And you'll see from the studies that were done by CMS that some of the centers were very effective and some of the centers weren't, and what were the barriers that went in. I just want to make sure that everybody fully knows from our perspective as an association, we believe strongly that enhancing telemedicine in Georgia's rural communities can make a difference in the quality of care provided to the residents, but it has to be done so effectively. We also believe that it offers opportunities for significant cost savings in the healthcare system when used effectively. Why do we need physicians or telemedicine in rural Georgia? First of all, we have access issues and availability of physician issues. We may only have 2 to 3 hours per week provided in actual physician time in the centers. Availability of psychiatric services, and we have found that that is the #1 current use when we have surveyed our members about their current use of telemedicine. The limitations in psychiatric services and availability for our behavioral residents and our large population of dementia residents is critical. Specialty consults, difficult, as you have heard many times from many sources, getting specialty physicians and appointments and trying to avoid the transport that is required to get those appointments could be a great benefit in the rural community. And just having an opportunity to improve care, particularly when psychiatrists can do either group or individual treatment by telemedicine. We've listed 4 primary areas that telemedicine benefit nursing facilities: primary care services, behavioral psych services, specialty care services scheduled and as needed when you have issues, and wound care and continence care. Not all of these services will be needed in every center, but those are the 4 general care categories that they fall into. The rural primary care services, most of the companies that our centers contract with provide clinical hours of approximately 9 hours per day to see patients, usually Monday through Friday for these hours. Daily rounds if necessary with the centers, if like I said, if necessary. The biggest reason, if there's an acute episode, you have the ability when there's a change in a resident's condition. Some of these other things, one of them is critical, communicating with families, assisting with advanced care planning, and obviously documenting their visits. Again, the #1 use right now of telemedicine services is behavioral psych services, particularly dementia, behavioral manifestations, and we are seeing an increasing prevalence of depression and other issues that are being dealt with. Clearly, the use of telemedicine helps enhance staff training and support, having physicians available or psychiatrists or psych services available. and provides for quicker support. And obviously, from our perspective, we use the term FTAG response. It allows us to meet our regulatory requirements and prevent negative outcomes. These are the primary consultation services specialty that I've listed here. They integrate with the attending physicians as well. And then the most common telemedicine episodes, shortness of breath, fever, change in mental status, GI, chest pain, falls with injuries, as you can imagine, and behavior changes. And these are the most common diagnoses that are related to those issues. You know, what does it do to improve the clinical and social impacts in the center? It provides for early treatment of conditions. Our number one concern, reduced emergency room transfer and rehospitalization. State survey assistance. Again, we're always looking at it to make sure we're in compliance with CMS and the state's guidelines. Medication stewardship and being responsible for coordinating the overall. You can imagine the number of drugs that most of these individuals have. It's really, the studies have shown that the use of telemedicine really improves the nurse satisfaction and hopefully leads to workforce retention. You know, here are some of the statements that were found in the studies from the nursing staff. When I call the doctor, he answers the phone. Increasing their skill sets and confidence, which is truly one of our greatest challenges, to make sure we have access to the RNs that are capable to do that. The families tend to be happier because they know they're getting immediate attention from a physician. And the physicians, the attendings, are usually happier because it allows them to be able to ensure that their patients are being cared for quicker. The first case study that Mr. Whitman brought to us was related to a study in New York. It was a 350-bed facility. They found that they had 91 avoided admissions in that center, a savings of $1.3 million for Medicare, and $132,000 additional revenue for the center. Obviously, better care for the seniors, reduced system cost, and I'll say this again when I get into the detail. Medicare is the typical saver because Medicare doesn't have to pay for the rehospitalization. Medicaid, on the other hand, will have a slight increase in cost, which is where this revenue enhancement to the center comes from, because individuals that don't get admitted to the hospital are still going to be paid for by the Medicaid system. So that's why the nursing center can have an increased financial performance. But the overall system benefits. And there are some potential savings for Medicaid as well. The second was an AHCA grant in Florida. And that particular grant looked at 4 nursing centers to evaluate whether they could prevent avoidable hospital admissions. It started in 2017. They had 4 centers that were selected in both urban and rural settings, and they had 2 virtual physician practices, and the study included 8 months. Not important where they were to us. The study's goal was to evaluate the ability to reduce those avoidable hospitalizations and see what the economic impact would be to the healthcare system, and then to evaluate the impact on the skilled nursing centers, the physicians, and their employees. The findings from a clinical perspective were significant. It increased the ability to provide bedside evaluations, not just phone calls. It allowed them to prevent rehospitalizations. They could use the local ER when needed, but get the resident back without the need for the rehospitalization. Improve clinical skills and confidence, which we think is going to help stabilize the nursing workforce. And there were some other benefits, but mainly it was a better healthcare quality outcome, and it reduced the overall system healthcare cost. For the skilled nursing facility, economics were positive in both the urban and rural. As you might expect, they identified in the study it was hard to change the status quo. People were slow to react and change their methods. It became critical to gain the administrator and the DON's commitment, the medical director's commitment, and gain the nursing staff's commitment. It required a lot of regular education and re-education. It became a market differentiator. Those centers that were providing the services had a capability to increase their admissions because people wanted to be in those settings. And hospitals obviously responded well because it prevented them from being penalized as well. The physician companies, they determined that the quality of the physicians on the other end were critical. It made all the difference. They had to understand skilled nursing facility residents and provide the care, and they had to be excellent communicators with the residents, the center, and the physicians and family on the other end. And the equipment had to be easy to use. One of the things from a financial perspective, in that study, only 2 of the 4 centers were financially successful, but Medicare was financially successful in all 4 centers. And again, as I noted earlier at the bottom, Medicaid actually pays more when the admission of a Medicaid resident is prevented because you're continuing to pay for the skilled nursing care. But obviously for a Medicaid-only resident, which there are probably about 20 to 30% of those in our centers are Medicaid only. Most are dual eligible, Medicare and Medicaid. When we prevent a rehospitalization for a Medicaid-only resident, we do save the Medicaid system money as well. And these were the final thoughts on the study that Mr. Whitman and the report made back to Florida on that. And we're going to talk about that just real briefly, and then I'll sort of get into the wrap-up. But effectively, they found that telemedicine was dramatically effective and good for the resident in improving access to care and the quality of care. It contributes significantly to Medicare savings. It's not for every skilled nursing facility because you've got to ensure that certain critical success characteristics must be present. Well, when I got this presentation, I'm sure your question, because it was my question, is what are those successful characteristics? And we've summarized those. We asked Mr. Whitman to summarize, and that's on the next slide. Not all physicians buy into the telemedicine in the short term, but it's critical for the success in the long term. And not all virtual companies will be successful. They also have to have certain characteristics. Again, the number one of the most critical success characteristics was having a stable internet and reliable internet. The IT technical support was one of those things that when you looked at it, you not only have to have IT services for the equipment, but you also have to be able to modify the residents' rooms to ensure that you have access. If you have a unit that is actually going to each of the residents' rooms for being treated, or you may have to modify your infrastructure to create a telemedicine room in the center. It's one of the biggest barriers is how do we deal with the infrastructure issues in really old nursing centers? How do we create the internet access in each individual room? How do we create the internet access? Or how do we modify our plant to be able to accommodate if we have to move the residents into a telemedicine room? How do we accommodate the infrastructure changes that are there? Nursing center leadership has to be supported. It has to be supported by the administrator and the director of nursing as well. But we also have to have an engaged, licensed nursing staff in which we have provided enhanced clinical capability to be able to make the critical decisions about when to call and when to utilize the telemedicine services. We have to make sure that we have medical director and attending physicians that are also bought into the system, that they're not fearful of losing their patients to another physician. And the greatest Georgia challenge when we talk about it is the availability of RNs and the workforce issues that I know you will be talking about over the next few months. We were asked to also look at earlier, what is the reimbursement? As I said, Medicare will only pay for services that are delivered in a county outside of a metropolitan statistical area or a rural health professional shortage area in a rural census tract. I put the links to those resources at the end of this presentation if you want to look at the areas that they'll pay for. The reimbursement for the clinician at the remote site is actually made through the Medicare Part B fee schedule based upon the type of visit. The reimbursement for the nursing center is an originating fee meant to cover both the IT readiness and the equipment, which today is $25.76 per visit. And then the Georgia Medicaid program covers both urban and rural visits. And again, the physician is paid based upon their fee schedule, and currently it's $20.52 per visit as of July 1 of this year. Now, these were the findings from the studies of what they would do. I would tell you that some of these don't directly relate to you. Medicare should be reimbursing for telemedicine in urban and rural. Again, that's a CMS issue, and I know Director Elmers has indicated that's one of her key goals is to eliminate that barrier. So what we look down to the bottom is what was our role as an association in making recommendations. The first thing is we are taking a very active role in encouraging our members to evaluate telemedicine for their residents. We are working with Mr. Whitman to put on a number of webinars, and we're working with Leading Age Georgia, another association here in the state, to coordinate that effort. We're also working with organizations to help. When we said state CMP grants, it's actually CMS CMP grants that are recommended through the Department of Community Health. So we're putting together a template that will allow our provider community to be able to utilize, to be able to request grants to assist them in providing these services and help improve the quality of care and access to care. Again, our final recommendation and some of our challenges, obviously the one that you're working on and have been working on, access to the stable and reliable internet. ITC resources locally, we're trying to evaluate how we can help assist our members with companies that are able to provide those IT support services because they're not always available in rural communities. multifaceted physician practice groups that are available to provide those actual telemedicine examinations. We've asked a couple of different groups. There are obviously companies, and Dr. Sumner, I'm sure, will talk a little bit more about who they might be and how many of them there are. But one of the challenges that we're finding is simply being able to find the number of companies willing to provide those services and be available for us on a 24-hour basis. And then, as we've mentioned multiple times, probably what we consider our greatest challenge is ensuring that we have the engaged licensed nurse staff, particularly the RNs in our centers, that are capable of helping to make those decisions about when it is proper to use those services. I'm sorry. And then the one thing, I did provide the resources for Medicare and Medicaid that are available, as well as those workforce shortage areas where they will actually pay for services. And with that, I would take any questions you might have.
Are there questions?
I have questions. I've got comments.
Sharon?
I'd like to make a suggestion. I
Yes,
know
ma'am.
you have to have a certain number of RNs for rating, but I would suggest that LPNs today and the ones working in your centers are much more in touch with the patients and what's going on than the RNs are. It's my understanding. It seems like the RNs are held up with paperwork and making care plans and the kind of things that are being required of them to send in to the feds. And if you have a really good licensed practical nurse in these centers, and I think this was something that maybe you need to look at, the group developing these LPNs, many of them are able to say and tell the difference if it's something they can take the time to call and set up telemedicine quickly, or call 911 to send somebody to the hospital.
Right.
And so I think instead of just bemoaning the fact that you don't have enough RNs, try going that route. Because they are the ones doing the bedside nursings that know more about the patient's actual condition often than the RNs do.
Got a question, Mr. Chairman? John?
Right here.
Oh, sorry.
One quick question. The 138 rural skilled nursing facilities that you have, you mentioned internet access. How many of those 138 do not have internet access? Do you have that number?
Do not have that number, no, sir.
Could you get it?
We can ask. We'll certainly try. We've done multiple surveys and asked our members to let us know which centers are actually providing telemedicine today, and we've gotten a fairly low response rate. We know that it's probably only about 15 to 20% of our membership providing those services today, but I can see if we can get a better answer on the broadband services.
Don?
Thanks, Chairman. Thank you for your presentation. The question or your answer to John was part of what I was going to ask, but early on in your presentation, you had a slide there. You showed a piece of equipment, and you kind of described
Yes.
what they could do with it and things like that. I guess my first question is that do many of the nursing homes have that, going along with the broadband question?
Yeah, the answer is that equipment does not exist today in most centers. That is the initial investment that would be required for equipment, and then any infrastructure for IT services or telemedicine rooms.
I mean, I appreciate, great presentation, I thought, and I think your description of what it can do is, in my mind anyway, is pretty much exactly what telemedicine should be about.
That's right.
So I appreciate that. And, I have a mother in a nursing home, and I see these people, and I'll probably be there myself one day, but the less you can prod them and move them around and things like that and aggravate them, the better off everybody is. But then the only other question I have is, I was a little bit confused about, you had said that some of it would be covered by Medicare, Medicaid, but I think you said something about the stored information or something like that wasn't covered. I'm not sure what that, what.
Yeah, effectively, if you have, you talked about some of the services in the earlier presentation this morning, monitoring blood pressure checks, monitoring glucose levels, monitoring things that you could electronically capture and send to a physician for evaluation. If you had a heart monitor that was done, those types of services are not covered and paid for by Medicare and Medicaid. It is only that live, interactive, live stream examination that Medicare or Medicaid will cover. They call them what are called store and forward, is the technical terminology that Medicare and Medicaid use. If it's technology that you're storing and you're forwarding to the provider, x-rays, other things that they simply are looking at and then evaluating, any of those monitoring services, there is no reimbursement to the nursing center for an origination fee. The only thing is that live interactive streaming.
Any other questions? Thank you very much.
All right, thank you.
All right, our next presenter is Dr. Jean Sumner. She is a third-generation rural physician and an advocate for rural health and the need for quality health care in rural communities. She is currently the Dean of Medicine at Mercer School of Medicine. And let's give Jean a welcome.
And she's wonderful and smart.
Good morning. Thank you for the opportunity to be here. I apologize. I thought we had a little break. And I live with a family of editors, and I had a lot of editors weighing in on my slides, so I'm going to swap out. Same pictures, same content, just better grammar, less commas. Thank you for the invitation to come today and talk about something that I do care a lot about. Thank you, too, for the work you do, because you know, I know that y'all know that I'm passionate about rural, but this group has spent so much time looking at the problems of rural Georgia. You are truly servants. At one point, I've said to many of you, I thought about running for state representative, and my husband kept saying the only job harder than being a small town doctor is being a state representative. So, thank you for what you do. I'm an internist by training, and when I went home from medical school, I walked in. My father had been practicing for 42 years and had developed a nursing home practice because his patients went to the nursing home. And my older brother said to me, "I hate the nursing home, you're the nursing home doctor." And in all honesty, that wasn't what I intended to do. As an internist, you spent time taking care of really sick patients in tertiary care hospitals, and the nursing home didn't seem very exciting to me. But about 2 hours after my assignment occurred, a nurse called me, Ms. Wileen Lewis from the ECF in Sandersville, and said, "Dr. Sumner, I have a patient I want you to see." And I said, "All right, Ms. Lewis, what's wrong?" And she said, "She's sick." And I said, "Well, what's wrong?" And she said, "Well, she took her glass of iced tea and poured it in her soup at lunch." And I said, "Well, does she have a fever?" She said, "No." And I said, "Well, is she complaining of anything?" She said, "No. But she poured her iced tea in her soup." I said, "All right." So I thought this was my challenge. You know, I was the new doctor, and she was going to get me over there. So I went over to the nursing home, and I examined this patient who was 99. When I walked in the room, she was reading the paper. She greeted me. She told me she'd been my father's patient for however many years. She was glad to see me. I examined her from the top of her head to the bottom of her feet, and I found nothing wrong with her. And Ms. Lewis said, I said, "Ms. Lewis, there's nothing wrong with her." She said, "She's sick." All right, well, I'll make you happy. I'm going to order some lab and x-ray. So I ordered a CBC and a chemistry and a chest x-ray and a urinalysis, and at Ms. Lewis's urging, a urinalysis and some blood cultures. and went back to the office sure that I was right and Ms. Lewis was wrong. 2 hours later, she called me and said, Dr. Sumner, our patient has a temperature of 104. So I promptly went back to the nursing home. But what I learned that day was listen to the people that care for those patients. And if you're in a good nursing home, it's the little things that matter. Within 12 hours, the lady's blood cultures were positive. She was septic. But we never put her in the hospital. We started IVs, we started antibiotics. Next morning, I went to see her, and she was fine. And what I appreciated about it was how little I knew about taking care of geriatric patients. But I learned from some really good nurses how to do that. And I begun to really understand that the care in a nursing home is based on science. There's a lot of information you need to know. You have to address it aggressively. One thing I knew when I went through medical school is I did not want to be a pediatrician because the parents were worried, and I know as a parent, you get worried and they put a lot of stress on you. But in long-term care, you have the children that are worried, and so it was sort of the same dynamic. But I enjoyed nursing home care a lot, and I ended up being medical director of a number of nursing homes because nobody else would go to the nursing home. And I enjoyed it, and so I spent a lot of weekends and holidays and nights at nursing homes, but I enjoyed that a lot. This is Gladys Hendry. One time, Georgia Public Radio called me and said, you have some older patients we'd like to interview. Miss Hendry was 100, and she was living at home, and wanted to know if they could interview Miss Hendry and some other patients I had, and I said, of course. So when the reporter came in to interview Miss Hendry, and Miss Hendry ran a 2,500-acre cattle operation by herself. She was a single parent. Her husband had left, died early on, and she was by herself. So the reporter came in and sort of condescendingly leaned over and said, Miss Hendry, tell me about your cows. Miss Gladys looked up and said, you want to know about my cow-calf operation or her genetics? And she ran that operation till the day of her death. What I learned about this generation is they deserve the best we have to offer. They changed this world. They changed this country. They fought world wars. They tolerated. They do not ask for much. But what we as providers must give is the highest quality care that we can provide. I saw a gentleman that spoke to you yesterday briefly. I was kind of in and out. And the only thing I really saw is he had a triangle. And he had access, and he had quality, and he had cost. And he talked about if you increase one or decrease one, it affects the others. And indeed it does. But the cheapest care you can pay for is the best care. Because if you increase access and its quality of care, you're going to decrease cost. And in nursing homes, there's so many opportunities to improve the care, and we've got to change that dynamic. But I do care about that. I'm not going to belabor the statistics. The gentleman before me certainly was more knowledgeable about these than I. But you pay for Medicaid, and I'm going to talk just about pure Medicaid, the state program. You pay for room and board. And in Georgia, about 73% of the beds in Georgia, or certainly more than that in rural Georgia, are Medicaid beds. And so how can we look at, Mr. Beerman, when he called me, asked me to look at some cost factors and how telehealth could impact them. But I really do think there's lots of opportunity. This is Miss Margaret Isom. She was a patient of mine. She loved chickens, and all she wanted to do was go hold a chicken, and so we arranged for her to leave the nursing home and go to chickens and hold some chickens. Nursing homes, 85% of patients in a nursing home are over 65, 42% are over 85. These are frail, elderly people. Most are women. 76% are non-Hispanic white people. Nationally, there's a 63% Medicaid rate. It is important to recognize that at least 50% have a dementia or memory disturbance. There are multiple types of dementia, and about 50% also have depression as a part of that or as a single diagnosis. Very commonly, families will say, this nursing home is boring. It's just so routine. There's just not enough going on. When you have a memory disturbance, a solid routine is good for you. It's safe. If you walk up to a patient with a memory disturbance and say, do you want a bath? They will say no. If you say you want $1 million, they will say no. If you say, Miss Jones, let's go get your bath, you have much better chance of getting that done. At Christmas, when the bands come in and the church choirs come in and they have activities, they call me over and over saying so-and-so is agitated. The change in environment is difficult for elderly people, so therefore telemedicine, as we use it, decreases that change in environment, decreases unnecessary transfer. The future is pretty scary, and that those turning 65 years or older, that today 2/3 will need long-term care. Now, long-term care encompasses more than just nursing homes, of course, but 46% of the people in this room will probably spend time in a nursing home. Americans turning 65 now will spend at least $136,000 in long-term care services. And the number of Americans turning 65 will double up to 88.5 million by 2050. And I think the gentleman before had some, that was scary about 2030. It's closer than that. Someone asked me what the fact that the South, and in particular Georgia, has so many facilities, what does that have to do with the future? Those facilities are at the high end of cost. We have nursing homes, we have assisted living. We've got to transition to community-based care because we cannot afford to put those individuals in institutions. And most people want to stay home anyway. Who wants to go to a nursing home? A good nursing home is a treasure. And you will have to go there probably, and I'll probably go there. And sometimes you have to use those services. But we need community-based care that delays that admission to nursing facilities. If the patient is safe and can receive quality care, telemedicine can help with that as well. Both my parents ended up in the ECF in Sandusville before their death. Both could afford in-home care. They have 3 children that are physicians who saw them every day. There was no way we could care for them at home. They needed a quality nursing home. I understand that. And we were blessed to have a really good one. But nevertheless, we need to look for options to keep individuals in the home longer. I don't want to insult you with explanation, but I find a lot of physicians that don't know a lot about Medicare and Medicaid and things like that. They just don't know the difference. That sounds scary, but it's true. But as the gentleman before said, that nursing homes for Medicaid are paid based on a case mix index, which is really an indication of how sick the population is. So the more services that are provided those Medicaid patients in the nursing home, the higher the case mix index. So if I have a pneumonia and I can treat that in the nursing home, that case mix index goes up for all those Medicaid patients. That means that nursing home gets better reimbursement. But if they go to the hospital for that pneumonia, they spend a lot more money, and you pay for that too with Medicaid. But the 2 things that you can affect with telehealth is better physician services and decreased hospitalization. You pay for transportation. You pay for pharmaceutical costs, and that's a whole nother talk that we'll get into one day. But transportation is a disaster in this state. It is horribly expensive, and it is really difficult and not good for elderly patients to put them on a van and send them places. So I think the more you can keep them in a facility, the better they are. Now, everybody wants to define telehealth, and I really want to stop calling it telemedicine because it simply is the practice of medicine. My grandfather used to tell us when we were children that doctors, he finished at medical school before 1900, and he would say that the older doctors laughed because they used stethoscopes, and they call that technology, and they would still make it a practice to put their ear to the chest and listen to the heart, so they thought it was pretty radical to use a stethoscope. We think that about telehealth now, but technology is a great way to practice medicine. In Georgia, the standard is the same. You cannot practice substandard medicine and be within the rules in Georgia. It's my obligation as a physician or a nurse practitioner or a PA to say, I don't have enough information. That's on me. The nursing facility's obligation is to present the patient. You have to have quality equipment, but it is not nearly as expensive as it used to be. You want state-of-the-art equipment in a nursing home with everything you need, it's $10,000 or less. If you're doing behavioral health, it's $5,000. The peripherals allow you to listen to heart and lungs, to look in ears, nose, and throat, and the connection is very simple now. The rules in Georgia, and I have copies if you'd like, but I gave you the link there, that anybody can present the patient. It does not have to be a nurse. it can be a CNA. And one of my experiences, a certified nursing assistant, is the CNAs were a lot better with technology than a lot of the nurses. You know, they could run they all had cell phones, and they could turn that machine on and get it up and running and present that patient. The doctor gets to say whether they're seeing what they need to see, or the nurse practitioner. So you don't need to have a person to present the patient that is licensed. Though you do need to have a person who's licensed to take the orders and to respond or present information. It is successful when the patient is prepared. And when I send a patient to a specialist, if I don't send what I'm looking for, or send the question I want answered, and send the patient's information, and send the patient's records, I haven't done my job. And the same is true with telehealth. If I'm going to consult a specialist, I need to have that information to the specialist in advance. I need to have the cardiologist know what I'm asking, to have all the records, to have the EKG in the lab, and have the echo report, so that that cardiologist can see my patient just as if they were in the office and make a decision. If I don't do that, that's not good medicine. In the past, in nursing homes, and I'll refer to Scott Health and Rehab, which is my champion nursing home for telehealth, we did a heart failure clinic. The cardiologist loved it. The nurses loved it. The families loved it. We did psychiatric services, and I'm going to talk a little more about those. Those things worked, and it was the same quality as in person. The physician can bill, so why would they complain? The site can bill. Is the fee small? Yeah, it's small. But it's really what's best for the patient. So go back to what's best for the patient. Is it better to put them on a van and drive them 60 miles to Augusta to sit in a waiting room with the flu to see a doctor for 10 minutes? Or is it more efficient to take them down to the telehealth room, have them prepared, get the information to the doctor, and have them see the doctor, and the patients love it? Physician services, we're in a state where and I'm working as hard as I can to work on physicians and to get some doctors. In fact, one of the, I saw a list this week of applicants to medical school who were ranking, and most of them were from rural and South Georgia, and I was proud of that. We've got to address physician shortages. We've got to get physicians back into underserved populations in rural areas. We've also got to demand that physicians take responsibility for the frail elderly in nursing homes. And in many ways, right now, many of the chains hire physicians, and they are good guys, and I know most of them, and many of them are my friends. But it's very hard to cover large geographic areas of nursing homes, because in the nursing homes, you need to go. When you need to go, you need to go. You need to go in the morning, you need to go in the afternoon. It's hard to drive 50 or 60 miles to see somebody. If you're covering a nursing home that far away, telehealth works. The medical director is intimately involved. Being a medical director of a nursing home is a tremendous obligation, because you have a responsibility to oversee care. So if the physician who is caring for a patient is not doing his job, the medical director ultimately is responsible for the care of that patient. So telehealth gives that medical director an opportunity to examine the patient and to be engaged. Often, some of the nurse practitioner services that cover nursing homes in this state have huge geographic areas, and at night they may have 2 nursing homes on call for the state of Georgia. 2 nurses on call for the state of Georgia. They have an electronic medical record, but they've never seen the patient. So what happens? Go back to that nursing home in the country with 1 LPN, 45 patients, and 4 aides. Do you think she's going to hook up the telehealth unit and connect to me? She's calling 911 and then calling me and telling me the patient's on the way to the ER. We have to change that dynamic, because the worst place for that patient to be is in the ER many other times. And then they have to lay there for hours until non-emergent transportation comes back and picks them up and brings them back to the nursing home. Telehealth can really impact that. You know, I carry my camera with me all the time because there are a lot of good pictures out there, and I've taken a lot of pictures of vans, and this was one that pulled up at a nursing home. You know, we need transportation. We need to improve it. But there is a detriment to putting frail elderly people in a van and hauling them 60 and 70 miles. Nobody goes with them. The person driving has their own set of responsibilities. They get to a doctor's office. Many times they're confused when they go. They don't know what the doctor said. The doctor doesn't communicate with the nursing home. There's lack of continuity. You can't figure out what went on. So if you can bring that specialist into the home, you've done a good job for that elderly resident. Now, I'm like the gentleman before me. I stole this slide, but I really didn't steal it. I borrowed it. But this is Logisticare data, and it's national data. It's 32 states. But it shows, and I'm sorry for the size of it, but 38% of transportation is behavioral health. One thing that telehealth does better than anything is behavioral health. It is quality service. Dr. Kirkson, who works for Care Now, and I'm going to show some slides he sent me, has attended patients at Scott Health and Rehab for, I think, 7 years now. You find one other psychiatric patient who goes to a center for care who's seen the same psychiatrist for 7 years. He's part of the family. He knows the patients. He knows the family. He knows me. When I was there, he knew me. He knows the attending doctors. He knows the nurses by name. You can pick up the phone and call him anytime, or whoever's covering for him. So he is ingrained in that community, and I think he lives in Atlanta. I quite honestly am not sure where he lives. I've never seen him in person, but I feel like I know him. Logisticare made, in 2015, 4 million trips in Georgia. That's 47.4 million miles. There was $43.5 million spent on transportation, and of that, the state spent $25 million. Now, I know you block grant that or you send that in bulk, but you can save money on transportation through telehealth while providing the highest quality of care. Things change. We don't grow tobacco anymore, though my neighbors planted this tobacco field and it was drying, and it was almost like a circus of people circling that field to look at tobacco because they hadn't seen it in so long. But we have to look at the way we incentivize transfer. We do. It's easier to send a person to the emergency room from a nursing home sometimes than it is to treat them in-house. It's somewhat incentive to have a 3-day stay in the hospital to increase the Medicare reimbursement when they come back to the nursing home. And then everybody's afraid of liability. All those things, I believe, can be addressed through telehealth. Staffing is certainly always an issue and needs to be addressed, but you don't have to take your most skilled individual to use a telehealth unit. Hospitalization, I hope one day Medicare gets the word that you don't need to be in the hospital. You shouldn't have to require somebody to be in a hospital 3 days, because a hospital is not always a good place for a frail elderly person. It's really a dangerous place sometimes. And physicians who practice really good medicine and do the best they can, liability is going to always be there. You're just going to have to do the best you can and pray it doesn't happen. As long as you've done your part, I think your risk is minimal. There's no difference in your liability through telehealth and in person, though, in nursing homes. We have worked really hard for the last few years at Mercer to try to work with emergency medical services. And I greatly value the EMS in this state. They do incredible work. They are skilled health professionals that serve a great void. But we have a payment system that incentivizes transfer. And we've got to look at the way we pay EMS. When they come to the nursing home, say they had a telemedicine unit, the nursing home didn't, and they could connect to the ER for somebody they knew was truly not emergent. They're not getting paid for that. They may get a presentation site fee because we have a waiver that makes that ambulance an origination site. If they take them to the hospital, it's $300 or $400. They're on a stretcher, it's more. Even if they don't need to go. So frail elderly ladies end up in an emergency room for hours in a place they don't need to be, where it's not the best care for them. I have a patient that called me over the weekend, a former patient that called me over the weekend, who's taking care of her elderly brother-in-law, who actually worked for the city of Atlanta his whole life. He worked as a bus driver, and he never married, and he saved all his money. And then he broke his hip, and he had to come to Sandersville to the nursing home to be cared for. He doesn't qualify any state aid because he got money in the bank, and he needs cataract surgery. She was smart enough to buy him a plan that covered transportation. He has 9 round-trip visits this year. So she made an appointment with the ophthalmologist for him to see cataract surgery, and she took him over there, and they said, yep, you need cataract surgery. Come back next week, and we'll do your pre-op. One more visit. Came for pre-op, and they said, you know, we want you to see the cardiologist and the pulmonologist before we do your cataract surgery. I said, okay. Cardiologist was in Augusta, another round trip. Saw the pulmonologist who was in Augusta, another round trip. Now they want him to come back for another pre-op. Then he comes back for the surgery. Then he comes back for the post-op. It cost her $500 a round trip to go back and forth to Dublin or back and forth to Augusta. It won't take him long to qualify for Medicaid because he's going to use up his savings. But the point is, you can do excellent pre-op evaluation through telehealth. Ophthalmology and telehealth really works. Now, most nursing homes and cities don't have that equipment, but in other states, they're doing great ophthalmology exams through telehealth. And I hope it'll come to Georgia. But it does decrease transfer. Care Now is a behavioral health service that's active in Georgia, and I referenced Dr. Kirkson. He works for that service. They offer board-certified psychiatrists, psychiatric nurse practitioners, licensed clinical social workers, licensed professional counsels, and they serve rural nursing homes across this state. They do a great job. They're responsive. They're part of the team. You get the same doctor. They answer the phone 24/7. You have a patient that gets out of control, you can pick up the phone and talk to them. They can immediately connect through telehealth. They can sign 1013s, and they develop and work at developing relationships with families. They also do a lot of in-service for staff, and they teach about drugs to avoid. There's something in, I know at least one of you is a pharmacist out there, but there's something called the Beers List. The Beers List is a list that was developed of medications that should be avoided in the elderly. Things like Benadryl. You should not give older people Benadryl. And true story, I was given a talk on the medication management one time, and it's named for Dr. Beers, who was in the Northeast, a famous doctor who listed these medicines, and it's been continually updated through the years. I have a neighbor who likes to imbibe, and I knew I could borrow some beer cans for him, so I went over to his house, truthfully, got a load of beer cans off a 5-gallon bucket that he kept on the back of his truck where he throws his beer cans. And I brought them back to my house and set them up on the back of my husband's truck. It's a true story. Sunday afternoon, I'm going to take a picture for a slide, and somebody drives up, and I really thought it was somebody coming to see my husband, and I didn't pay any attention, and somebody said, hey, and I turned around, and it was the preacher. And I had all these beer cans lined up, and my first response, being a Southern woman, was, could I get you something to drink? You know. But anyway, they weren't my beer cans. But Care Now Services truthfully raises the bar. It helps the nursing staff understand why you don't give Benadryl and why you don't give atypical antipsychotics. And it improves the quality of care. This is a slide that I got from Care Now Services, which I think is impressive. They did a study with CMS over the course of a year in Georgia with 6 nursing homes. And this is monthly psychiatric consultations in nursing homes. In June of 17, they did 401 consultations. Look at that. It's over 1,000 consultations that you didn't pay transport for. More importantly, the patients got superb care. And try to find a psychiatrist for a nursing home patient in this state outside a nursing home. It's hard. You can't find one for even state insured patients. It's really tough. This is Dr. Kirkson's slide too. But I think it really is important to look at data from this company, and that they have legitimately decreased the use of medications in nursing homes because they give quality of care. And most importantly, they're not one of those services that works at their convenience. They're real doctors, real social workers, real counselors who are available when you need them. That's the quality we need for nursing homes. This is a busy slide, but the point I want to make, and you'll hear that doctors just don't like this. They're just not going to use it. They're not going to utilize it. On the bottom here, it says, these are psychiatrists and how they rank them. And you see that on the left, on the darker blue, is 0, and to the right is 5, and 5 is the highest. That is basically effectiveness and satisfaction of telehealth. Every psychiatric residency now is required to have a telehealth experience. Psychiatrists say it's safe and effective. These are the guys that use it, and they're the ones sticking their neck out, so they believe this is a quality product. You know, through the years, one thing that I tried to do and did not always do, but tried to do, when you get patients who come to nursing homes from hospitals are sick people nowadays. They are sick. The nursing homes, the hospital's goal is to get them out of the hospital quick. They get them out of the hospital quick. And they come to your nursing home, and what they say, if you don't know that patient, if you know the patient, it's one thing, but if you don't know the patient, they'll say, he's doing great. Had a patient that was doing great one time and ended up on the ventilator 15 minutes after he got to our nursing home. He wasn't doing great. They just wanted him out of the nursing home. But so I always felt like I needed to be there quickly when they got there. If I didn't know that patient, I wanted to be there pretty quickly after they got there to review their medications. And I cannot tell you through the years, and I am not overstating this, how many times that if I had not gone, the list of medicines the patient was on was lethal. They'd be on 8,000 milligrams of Tylenol because nobody looked at the medicines. They'd be on 2 blood thinners. They'd be on a non-steroidal and Coumadin in a frail elderly person with renal failure. And so it really is important that you have an engaged clinician right off. And there are great nurses in some of these nursing homes, and they know it, but they don't have the power to adjust that list of medicine. You can do that through telehealth. I can tell you that Oconee Healthcare is over 50 miles from Scott Health and Rehab, and I have made that triangle multiple times. That's a long way to go. There are no red lights much, so thankfully it's not Atlanta, but you know, you need to be in those nursing homes quickly when a patient comes because they're sick. You could do that with a pharmacist. A pharmacist could do that medication management. They're probably not paid for it, but nevertheless, you know, it's important. I take call with, when I was in practice, my partners were great guys. And I knew, and when I left, my patients were cared for. The problem is they were also very, very, very busy people. They had more than they can do in a small town. And so it was not uncommon for the nursing home to call and say, I've got Miss Jones. She doesn't look good to me. The call coverage didn't know her. They couldn't look at her, so they'd say, send her to the ER. And that happens a lot. You're responsible for that patient. You don't want to assume that liability. You can't get the information you need to make a decision. Through telehealth, you can. Consultation with families. If you can engage a family member, and we used to have a joke that we didn't take patients with children in Atlanta because they all thought you were kind of dumb and you were in Wrightsville, and how could you possibly be competent, you know? So, but if you could engage them or see them face to face or have a conversation with them and let you know that you're going to treat their mama like it was your mama, and you can do that through a video conversation. Consultation with physical therapy. I've told you the story about Miss Davis who broke her hip. I had to go over to the Houston clinic this week, and the young orthopedic surgeon that I got to operate on Miss Davis is now over in Columbus, and I actually ran into him, so it was a good reunion. Miss Davis was 102 when she broke her hip, and if I had sent her to the hospital for 3 days, she would have gotten who knows what medicine. She probably wouldn't have eaten, and she would have not done as well. So I persuaded this young guy, who had actually been a student of mine, to fix her hip and send her back to the nursing home, and she was back in 23 hours. Now, I had to take the heat from the administrator who didn't get her a 3-day stay. I got it, but it was worth it. She lived to 105 and a half, and she never quit walking, never quit walking. And the orthopedic surgeon saw her on telehealth and checked her wound every day and interacted with the physical therapist. Now, I've had to promise him I'd be there when she got back, and I was. But it was the best thing for Ms. Davis, and it's the best thing for other frail elderly people to get back to that nursing home. Wound care, ophthalmology. I'm always shocked at the number of nursing home patients who are on glaucoma drops who have not had an eye pressure checked in 10 or 15 years because there's nobody to check it. And they'll have people that come in And if you've been in the nursing home, I've fired a few of those groups because they'll come in and they'll see 50 people in an hour and a half. You know, they'll just run through them. And the nursing homes feel the same way that I did, so we didn't have any trouble getting rid of them. You can do great eye exams through telehealth. So you talk about cost, and yeah, it doesn't make a lot of money for the nursing home. It's a small fee, but it's the best thing for the patient. But think about operationalizing it with family visits. No, everybody wants to chat with mom at night. I have medical students, PT students, nurse practitioner students looking for volunteer opportunities. What an opportunity to have a family visit. Hire a minimum wage worker, hire somebody for a few hours at night to have the telehealth unit and take appointments for families. You send ombudsmen all over this state, Do ombudsman's visits through telehealth. It's a great way to save gas mileage. What about special events? You know, if I can't be at my grandchildren's baptism because I'm 95 in a nursing home, or great-grandchildren, wouldn't it be great to be able to watch? And you can connect with a cell phone and see that. Graduations and weddings. Now, this will scare nursing homes, I know, but if you could put this in an isolated area in some of these rural communities and let that unit be used for minor urgent care at night, it would be great, so that I could go down there and have a blood pressure check and talk to the doctor at the urgent care instead of driving 45 miles to see him because I had a headache. You could operationalize it and charge a fee. If you put somebody in a van and drive them from Scott Health and Rehab to Dublin and back, it's $250. So, in summary, you need a study. There are no good cost studies on telehealth. Mercer did a retrospective meta-analysis of all the data out there in telehealth. And one of the problems with the studies, and I know the gentleman at Wharton's, he's done some tremendously impressive work, but they don't define telehealth the same. So they lump in everything together, and you don't know what they're talking about. Is it a video chat? Is it a full exam by telehealth? Is it remote monitoring? Is it an x-ray? Are they calling that telehealth? You don't know. So Mercer did a study of every published article on telehealth and tried to look back at cost. That's not the way you want to do a study. It's a retrospective meta-analysis of all the data. And the only thing that can be said is, we're not sure. We don't know. So authorize a study of quality telehealth versus no telehealth. Look at transportation, look at outcomes, look at rehospitalization. Give credit for enhanced case management to those nursing homes that have quality telehealth that prevent hospitalization, that have low hospitalization rate, not just rehospitalization, they're going to get dinged for rehospitalization, but hospitalization, because you really don't want that frail 88-year-old in a hospital if you can help it. If they need to be there, they need to be there. But many times they're there because the daughter's already nervous about her being in the nursing home, and they want everything for mama, and they send them to the hospital, and they come back with pressure areas or not fed or dehydrated or something else. Recognize physicians. Physicians are competitive little rascals. You know, I like for my hospitalization rate to be low when I was in the nursing home. And that didn't just reflect on me, it really reflected on the quality of the staff I work with. Recognize recognize homes that use telehealth for specialty consultation, because there's so much opportunity to screen through telehealth for eyes, to provide behavioral health, to provide cardiology services, to provide echo. And incentivize appropriate transfer by restructuring EMS payment schedules. I really believe that should be done. EMS are valuable, and they have to get paid. I understand that. They're an expensive service, but you have to, you have to look at what's best for the patient again. And sometimes when you pay somebody to transfer, they get transferred when they should not be transferred. Those guys are smart, and they really know who needs to be transferred many times. So, not the critically ill, but those people who call, you know, and I'm not being judgmental, because when you live alone, or you have nobody else, and you don't have food, or you don't have medicine, or you don't know how to get there or access the system, the only thing you know to do is call 911. And so we can change that. I appreciate the opportunity to be here today, and sincerely appreciate all you do, giving us, Mercer, the opportunity to educate physicians for this state. So thank you for your work, and if I can answer any questions, I will. And I wasn't talking an hour. My daddy used to not let us talk about the preacher, but on more than one occasion, he would point out the length the human brain has of the time frame. He said, you can't concentrate that long. He never said bad things about the preacher, but...
I need to talk to you about that. I've got one of those preachers. The brain can only endure as much as the seat can take.
That's right.
And we got padded pews. Any questions, y'all?
I don't have a question, but I certainly did enjoy your presentation.
Well, thank you very much. Thank you. I appreciate being here. Thank you.
I have found that every time I watch Dr. Sumner, she's doing the speaking, but I'm the one that winds up being worn out from it. She covers so much ground, and I wind up taking so many notes on everything she says, because I've jokingly said this to her in person, but I'm going to say it publicly. Dr. Jean Sumner is one of the true Georgia gems. In my thinking, for her ability, her intelligence, her care, her compassion, and her want to do good for people, and common sense. Common sense goes a long way, and we're quite often lacking in a lot of folks that get up and try to tell us stuff sometimes. But you know, of the things we wound up doing last year as a council that wound up making it into legislation during this past session, Dr. Sumner's influence was a great deal of a lot of the things that we worked on, that we've been continuing to work on. So I just want to publicly say thank you.
Well,
for that.
Thank you, Chairman England. You're very kind. I care passionately about Georgia and about rural Georgia, but it's your leadership that's made the difference. And the leadership of this council and the legislature is incredible, and your interest and your knowledge of the problems. And I know how hard you're working to help solve them. We want to be part of that solution. It will take every one of us. It will take every one of us. And so there are no turf battles in my mind. If somebody does it, great. I mean, it's exciting to me to hear some of the things that go on. So thank you very much, and I appreciate the opportunity to be here.
Share.
For the committee, I think you ought to know that Dr. Sumner comes from one of our poorest, I think it's one of our poorest counties, isn't it, Dr. Sumner?
Well, I'm from Sandusville, but I'm doing mission work in Johnson County for the last 40 years, yeah.
Okay. But
I'm from Johnson County. We live on the line, though, Chairman.
But I think the committee needs to know you started out as an RN.
I did.
Okay, and then you did nurse practitioner?
No, actually, I'm so old that in my day, they called them
Certified nurse.
I can't remember what we would call it. But I got a master's in nursing, yeah.
Right, and then
Clinical nurse specialist is what they called them.
Right, and then there was no one to take care of those patients, and you really needed a physician in the area, so you drove back and forth to Augusta to go to medical school.
Well, Mercer's in Macon, but I went to Mercer.
Okay.
But I went back and forth to Augusta to nursing school. So I'm a graduate of the medical college. I love the medical college. Got a master's from there. But I'm from a family of physicians and went to nursing school. And truthfully, I know it sounds corny to these young people. I tell the young people this. I didn't even know any women doctors. You know, I came from a family of doctors. Had an aunt that went through Vanderbilt. In her third year, she married a neurosurgeon, and the dean told her, this was in the 40s, and he said, the dean called her in and said, your husband needs a wife at home, not a doctor at home. And she quit. And I said, Aunt Jenny, I was named for her. I said, did you regret that? And she said, heck no, I'd be working the rest of my life. So she taught college. But I went to medical school. I married Joe and moved to Wrightsville, and there was no health care in Wrightsville. And you know, and I came from a family, I never thought about healthcare, from a community with one of the first hospitals in Georgia where the first gallbladder surgery in America was done. And moved to Wrightsville, and it was just 25 miles, but people died because they could not access care. And nobody was coming. Nobody was coming to our county. And unless you did it yourself. And I don't mean to, I mean, I didn't do it alone, trust me. It took, I'm not gonna quote a Democrat, but it did take a whole village. You know, it took us all to get me through medical school. I never met my children's orthodontist, so I paid him, but I didn't ever meet him. But I appreciate your interest in that.
And it's just that Terry talks about how unique you are and what a treasure you are, that
You're kind, you're kind.
that not needing to do that and on when you were older in your life and with family would do what it takes because of a need in your community. And there are three people who are sitting. I think we could vie for who's the biggest Gene Sumner supporter.
Let me say
and
honestly,
appreciator.
there are
So-
so many good doctors out there, and there's so many good nurses out there trying to do what they can for rural Georgia, and they're the people that deserve to be recognized. They're out there. I'm just their cheerleader right now, and we need to recognize their service as well. They're trying, but we've got to help them stay there. We've got to find ways to keep them there, including, I know I'm married to a pharmacist, but including pharmacies. Pharmacies under attack right now. We've got to do things that are innovative and change healthcare in this state. You guys are doing it, so thank you.
Butch, hold on.
Jean used to be my constituent until she was stolen by Matt and Mac over here. But I've known Jean a long time. Jean, one of the things this committee has worked on and been real interested in is what can we do to have more providers, especially in the rural parts of the state. I know you and I have talked about this and everything else. But one of the things that we learned when we went around the state was the amount of student debt that so many of these medical students had when they graduated. And we're asking them to go to rural areas to practice primary care and be reimbursed at a lower end of the pay scale because so many of the patients are Medicaid and Medicare. But tell us what's going on at Mercer and what y'all have been doing over there to try to help keep the cost of medical school down.
Well, thank you for the opportunity, and I think you know many of those things because you were responsible for a lot of them, but the state was kind enough to share with Mercer and other medical schools a gift back that was a penalty that was returned to the state several years ago based on, we had increased our class size in 2008 when there was a crash, and that money was allotted back to us. We chose to put that money in trust and to spend off up to 10 free rides a year. And so we hadn't quite gotten to 40, but we're getting to 40 free rides. Each of those scholarships go to a young person from a rural area who will return to that rural area. But we also understand that they have to have some basic business skills. They have to have strong clinical skills and clinical judgment and independence to go there and to be leaders. They also have to have a community, as the gentleman from the peanut co-op mentioned. They have to have support from that community. They're not business people. And the community needs to realize that a physician is a $2.5 million industry. He needs to be invested, or he or she needs to be invested in that community and be part of that community and live in that community. So we want to work with those communities to find ways. And we actually have one of our graduates who's going to Douglas. We've done that. We have 360 preceptors around the state in rural areas we send students to. And we do needs analysis and planning in that community for that community, because our students need to understand that as a physician, you're sometimes the most educated person in town, and you need to be community responsive. You need to identify problems. But we want them to see good doctors practicing good medicine in rural communities and the difference they make. And we also have the accelerated track, and as you know, Mercer and Texas Tech were the first two medical schools in the nation to accept a 3-year track. They pay 1 year of tuition, the next 2 years are free, and they're guaranteed a Georgia residency. And if a Mercer student gets a Georgia residency, there's a 90% chance they'll stay in Georgia. That has taken off in the last year just very strongly. We are working with other residencies that are interested in the accelerated track. We've been approached by psychiatric residencies and these students are committed to rural Georgia, so I'm all about a rural psychiatrist. And a pediatric residency who wants to, I don't want to make you nervous, but they want to put every entering resident they want to make it an accelerated track residency slot. That would turn out pediatricians from rural Georgia. They come out with 1 year of debt, and that is easily forgiven either by a community or a hospital or by Mercer if we have to, because they commit strongly, and the contract is not, it's not a light contract. They have a commitment. We work with them to give them the skills to be successful, and we stay in touch with them as they get out there. One of the first graduates, and I think you know this young man, to finish through his residency is in a small town up in North Georgia. He was named one of the 12 most outstanding family medicine residents in the nation. Those students do well academically. It's a fast track, it's the same curriculum. So we've been able to substantially lower our student debt, substantially for those, but we also put in a lot of programs on living a frugal life. And it's being, you don't have to drive the latest car, and you don't have to, we try to support our students, but they hear financial planning from the day they walk through the door, because there's nobody to pay off those $400,000 loans anymore. Not only that, their incomes are dropping. If you look at physician incomes, not just in rural areas, everywhere. And so there's not going to be anybody coming to pay for your lifestyle borrowing. You've got to live conservatively. So we work on that, but those two programs, the Nathan Dill Scholars and the Accelerate Track, have been hugely meaningful in lowering student debt. You can go to medical school for free. And when you see that, when you talk to young people who want to go to medical school, I talked to a young woman yesterday, when she found out that she was eligible for that scholarship, it was a game changer. I mean, she didn't think she could go. She can go. And she's great. She'll make it. So we're committed to that. The other thing, I know that many of you have seen that we opened the clinic in Plains. And we, admittedly, President Carter called us, but we already had a plan to put primary care clinics out in rural Georgia. Mercer doesn't own a hospital. Mercer doesn't want to be some huge provider. We just want to have a place for our students to go. And I drove yesterday from Columbus, or Tuesday from Columbus through Webster, Stewart, Clay County, heading to Plains. I didn't go to Clay, but I went, the poverty and the lack of opportunity in those counties seemed obvious to me. You can practice medicine in that county, you will do well, but if Mercer has to put a clinic in those counties and support you and do your billing for you or whatever, we're not trying to make money on it. We're trying to get a viable practice out in those areas, because that's a starting point. And so we're doing those things, and we hope some of those Nathan Dill Scholars or Accelerated Track, if they need a place to go, we want to help them find a place to go. We want to work with that community. We're booked in Plains now through the end of October. We have X-ray, we have lab, we have a great family medicine doctor, we have a really good nurse practitioner. We have one of our graduates who is an OBGYN who wants to come work for us, and we're waiting to get her credentialed. Getting credentialed is a huge issue. She's ready to go. But getting her insurance plans, getting her on Georgia Medicaid is an issue. So, if she's a board-certified, qualified doctor who's been practicing,
Medicaid.
She's just changing practices. But we've got to overcome that credentialing thing, because they use it as a way to decrease cost. I got that. But it's decreasing access in rural areas.
Like that. Dr. Sumner, it's so important about our medical students and our residents having experience and in the rural area, so I thank you for doing that. Simulation's one thing, but patients react differently than the dummies that we use do, and so that's so important. But one of the things that I've said about rural communities, and I wonder if you've run into this, many of them have empty space sitting unused. And one of the things I said, having run a medical practice, if they would get people in the community to make that into a medical office and make it available either free or at the minimum cost, that would be a really big incentive for young physicians to come to a community. I mean, have you found any of the communities willing to do something like that to make the place where they work available? Because it's one of the biggest costs. And
I agree. And communities have got, you know, in Johnson County, which I am home to now and love, we built a spec building that sits empty essentially for several $100,000. But, you know, they don't think of, I mean, counties don't think about the impact a physician who's engaged in the community can make economically. You bring jobs to town, you bring, you know, industry doesn't want to come to an area where there's no health care, but it's got to be quality. And my thought is the physician's got to live there and be part of that community too. So, thank you very much.
Thank you. Well, I don't know. Forrest Gump said that's all I got to say about that. But any other discussion before a couple of final closing comments? Any other questions?
Yeah, Terry, I saw you writing over there during her presentation, and I think I know what you're writing, but anything she suggested, I think we ought to make that a recommendation.
It's pretty much on the list.
It's on the list.
It's kind of hard to keep up. All right, our next meeting, of course, will be in October in Brunswick. Room information going out shortly. Yeah. Okay. Dominic?
We've just heard a couple of times the last few days, and it's hard to wrap your mind around, but she mentioned not wanting that lady to stay in the hospital 3 days. And I think she said the administrator kind of got a little upset with her because she wouldn't get reimbursed if they were not in that hospital 3 days.
At a higher rate.
A higher rate. And so that just kind of ticks me off when you hear things like that, because it's like everybody's competing against everybody, and the cost of health care is going up, patient quality outcomes are going down, and it just seems like we're having a hard time wrapping our mind around this. And then the credentialing that I'm sure you probably make some notes about is trying to get this qualified, board-certified doctor, Medicaid, and go to rural parts of the state. And my final comment would be, how in the world do we start to pull those pieces out of that Jenga, the example he used yesterday? And I'm really counting on our co-chairman to help us make some recommendations through that.
Jay has that totally under control.
I do, because I've told Terry this is his last chance to fix the credentialing.
And we did address credentialing last year to some extent, and had thought that it was getting a little better, but I know Butch has hammered on that issue for 6 or 7, 8 years that I'm aware of, because we sat in our conference room and had a sit-in about 5 years ago with DCH and some others about that one particular thing on credentialing, because it was taking so long. And none of them were running concurrent to each other. They were all, once you got this one, then you applied for that one, and once you got that one, then you applied for this one. So sometimes it was, at best case scenario, 90 days, and a lot of times it'd be 180 days to almost a year in a lot of cases. But we will certainly circle back on that one, because one of the things that has frustrated me in that whole process too has been, I can't remember what the street address is of this building, but say it's 1011 Plant Drive, which I think it actually is, or something. Anyway, and we decide that, okay, we've worn this building out, so we're going to go to 1012 Plant Drive and build a new facility. You start from scratch again on the credentialing piece, because you've moved next door. And it makes absolutely no sense that that should be the case. If a doctor's already in practice, already been credentialed, already has everything ready to roll, there should not be a hiccup involved in that transfer process, because it makes absolutely no sense to me, and I don't think it does anybody else, but I don't there's a roadblock somewhere we've just not been able to find, so. All righty, Tim?
I know we have most of our meetings in the middle of the week, but, last year when we were supposed to be in Brunswick, there was a hurricane. So Coastal College is going through some renovations, so to make sure we had it and work around their schedule. This meeting will be on a Monday and Tuesday instead of the Tuesday, Wednesday, or Wednesday, Thursday we usually do. So just FYI, if you want to come down Sunday night. So I just want to make sure y'all knew that will change up. It's just a little bit different this time.
What's the date?
The 22nd and 23rd.
Oh.
Y'all got Coastal College of Georgia.
You don't have another hurricane scheduled, do you?
Hey, this last one scared me on this one.
I know. All right, ladies and gentlemen, we thank you so much. Thank you for enduring 3 days of very, very heavy and in-depth information and discussion. And Godspeed and safe travels getting back home. We are adjourned.